All right, I think we are live. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, May 31st of 2026. And it is time for another live IC support group meeting. This is for anybody who's struggling with pelvic pain, if you're struggling with interstitial cystitis, if you're struggling with chronic prostatitis, bladder pain syndrome, vulvodynia, endometriosis, pelvic congestion syndrome. Did I already say that? Anyway, if you got pelvic pain, I'm your girl. I've been doing these meetings I have been a support group leader for well over 30 years. We've been doing live support group meetings on the internet for many years now. And one of the reasons why we do that is because the network of regular support groups died with COVID. So as far as I know, there are no actual support groups meeting anywhere in the United States anymore, which is heartbreaking because before COVID, we had so many groups and now we have none. So where are you to go? Where can you go? Well, you can come online. And back when I started the IC Network years ago, my goal was to bring support to patients who were homebound. 30 years later, that is exactly what we're doing. But the internet is rife with challenges. I got to tell you, I did a deep dive into some IC support groups online, and I was horrified by what I was reading. Absolutely horrified. It's kind of like people have stopped learning how to read, and advocate for themselves. It's stunning to me that we've got patients going onto TikTok looking for medical advice. It's like, guys, it's an entertainment platform. And if you're struggling with pelvic pain, especially if you've been struggling with pelvic pain for many, many years, you're not going to get what you need from TikTok or from social media. You need to watch our masterclass. We have this free masterclass of 20 episodes. I've got 10 more episodes to add if I could just find the time to do it, which will give you everything you need to work with your doctor more effectively, to help you understand why we no longer consider IC a bladder disease. Guys, we don't. We don't. IC is a pelvic pain syndrome for which there are many potential causes, and our goal today is to try to identify the underlying cause. We don't want you to take a medication for the rest of your life that can make you go blind, which has no chance of helping. If you put a Band-Aid on a wound, what is it? It's a Band-Aid. It doesn't fix the wound, it protects the wound. That's what we're doing now with IC. We don't just want to cover up a wound, cover up something, cover up your symptoms. We want to find what's causing the symptoms in the first place. We want to treat that so you don't have symptoms in the first place. And so, it was interesting. I was working with a patient a couple of days ago who was diagnosed like 20 years ago, 25 years ago. And she was still operating with very, very old information. And I said, well, are you better? And she said, no. And I said, so can we then agree that the treatments that you've done to date are not helping you? She said, yes. And I said, then why are you still taking them? Why are you still taking them? Our national guidelines from the American Urology Association say if you are not responding to therapy, if you're getting worse rather than better, don't continue something that's not working. Stop what you're doing, take a step back, revisit the diagnosis. Because doctors 20 years ago, 25 years ago, were operating with bad information. And the tragedy today, and it's interesting because I was emailing one of my medical advisors. There are doctors right now treating IC out of old textbooks. Like literally, you come in, you've got frequency, urgency, pressure, pain. They don't find infection. They say, it sounds like you got this incurable bladder disease called interstitial cystitis. Here's an antidepressant. Here's a diet I'll see in 6 months. we are in a fabulous time right now. We have learned so much of it now. The problem is educating that local urologist who's treating it out of a textbook. Man, we can't even get them to read the guidelines. And we have guidelines, really good guidelines. We've had guidelines since 2008. I'm going to bet you right now, maybe 5% of those practicing urologists have read those guidelines. And these are not guidelines that I've made. These are guidelines by the best IC clinicians and researchers in the United States who have made these. So you have got to educate yourself more. Please watch my masterclass. We did it for you. Because I want you to be able to walk into that doctor's office, take control of that appointment, ask really good pointed questions so that we can find the underlying cause of your symptoms and treat the underlying cause of your symptoms. Don't go onto the internet, onto TikTok, and expect a good answer there. It's not going to be there. Now, one of the things I saw online this week was somebody who symptoms began after weightlifting. And you know what? We see that a lot. There's like this new trend in the last 2 years where people are encouraged to lift heavier and heavier and heavier weights. And one guy, his trainer, he'd already done a full workout. His trainer was like, hey man, let's just up it by 20 pounds. Let's see what you can do. Guy tried to lift it, popped a hernia. Popped a hernia really bad. Emergency surgery to repair the hernia. And then after that, he had all the symptoms of IC. Frequency, urgency, pressure, pain. Doctor said, well, must be prostatitis, must be interstitial cystitis. Let's give you a lot of antibiotics. Didn't work. And nobody ever said, until I said it to him, I said, do you realize when you were lifting that weight that you clearly injured muscles because you popped a hernia? It's like, yeah, you had surgery to repair it. Yeah. What about your pelvic floor muscles? Could they have been injured in that same accident? He goes, oh, I didn't even know. I didn't really even know I had muscles there. And I'm like, yeah, you need to go back to physical therapy. So anyway, there was this guy in one of the groups who's like, he's like, okay, my symptoms started while I was weightlifting. Not at all surprising. Very clear pelvic floor issue. And then he came online and said, would D-Manos help me lift weights? Heartbreaking. And as I very patiently tried to explain that D-Manos is about infection. It's about E. coli. It's going to do nothing to help you lift weights. I need you to educate yourselves more. I need you to educate yourselves better. Make a commitment to doing that. I don't know if you saw, there is this great clip from the Harvard College commencement. The speaker was so completely anti-AI. And he said, your job for your generation is to dismantle AI. Because the problem with AI is you're not learning. You're not learning the process. You're not learning how to write. You're not learning how to draw. You're not learning how to create stuff. It's like literally serving it all to you. And it was amazing I would encourage you to watch that. I was shocked. I mean, he was really using four curse words at this Harvard commencement. I didn't go to Harvard, but those things catch my attention. So anyway, I'm on a little bit of a rant. I am not happy with what we're seeing on the internet. Even the group that I thought was really good, I thought was the group leaders had completely abandoned good patient outreach. We're not educating patients well at all. And at this point in time, I am struggling to support some of that. And I created the first online support group. So, people call me the fairy godmother of the IC movement since the very first online groups I created. But when social media came on, people spread out and created their own groups, and some of those are scary. All right. So anyway, Normally, when I do these meetings, I have a little bit of an intro, and then I'm happy to take your questions. Some meetings last 5 hours, some meetings last 2 hours. I am here at your pleasure. Let me introduce myself again. Jill Osborne. I'm the founder of the Interstitial Cystitis Network. I've been a support group leader for 33 years. I have a bunch of college degrees. I got degrees in chemistry, pharmacology. I have a master's degree in psychology. I study, I see every day. I have been doing that for the last 30 years. I write books. We have our website. I'm a lecturer. This is just what I do, and I love doing it. And it's a Sunday, and while a lot of people are out enjoying this Sunday, I'm here for you. I'm happy to do it. I'm really happy to be here as long as you have questions. All right. Hello, Jennifer. We are simulcasting right now. We are on YouTube and we are on Facebook. Hello, Jennifer on YouTube. Hope you're doing well. Yeah, okay, so I ate popcorn before I went to bed and definitely felt it this morning. My stomach does not like late night snacks, but I got myself out this morning. I was out by 8, walking around the lake, seeing all the baby geese, and then I came home and I worked in my garden. So it's a good day for me so far, and I'm here, and that's always a good day for me. Hello, Anne. Ritz says, hello, I was on Elmeron for 2 years, had pain from time to time with bladder builder. I'm using it since 3 months, no pain at all. Yeah, baby. Excellent. Back to normal life. Do you think I should keep on taking the bladder builder or do any cystoscopy first? Well, there's no reason to do a cystoscopy if you're symptom free, if you're doing better. I mean, normally we do cystoscopies if you're not getting better, or if you're peeing blood, or if there's anything that concerns you, anything that concerns your doctor, I'm all for looking. Believe me, I don't like guessing. I like facts. My rule for my body is if I'm in pain, I want a doctor to look at that. And so I'm not saying cystoscopies are bad. I think they're important, especially if you're not doing well. But kind of the trend in IC care is a cystoscopy is only done usually if the diagnosis is in doubt or you're just not responding to therapy. So the fact that you are doing better might preclude that. Also important to understand that if you're having a hydrodistension with cystoscopy, you always run the risk of kind of injuring the bladder a little bit more. Hydrodistensions is where they stretch the bladder with water, hold it in there for a period of time, drain it out. Sometimes they do that twice, then they put a cystoscope in and look. The problem is that when you stretch a bladder, you're stretching the tissue. And that can be that, especially if they do it too much. We're supposed to do low pressure, short duration procedures, not high pressure. Back in the old days, they did a lot of high pressure distensions. They just thought the more you stretch the bladder, the better. But back then, bladders often ruptured and broke. If you were ever sent home after a hydrodistension with a catheter, or you were bleeding afterwards, that definitely shows that you were injured during that procedure. Hydrodistensions today are supposed to be low pressure, short duration. So I like that you're doing really well. So now the question is, should you keep taking the supplement? Well, so back in 2006, I have a freaky good memory for stuff like this. There was a big conference in San Diego. I know I was supposed to be there. I was supposed to be the MC for the entire event, but I'd taken a medicine that made my ears ring, and I wasn't allowed to fly. So I missed the whole thing, which is heartbreaking because I wanted to be there. Anyway, somebody asked Dr. Parsons, who happened to be the guy who invented Elmeron, will I need to be on Elmeron for the rest of my life? And he said, no, you just have to figure out if it's going to help you. So how do you do that? He said, you reduce the dose. So if you're taking 3 a day, you go to 2 a day for a week. See if your symptoms change. If they don't, go to 1 a day. See if your symptoms change. If they don't, stop it. See if your symptoms change. And that's kind of what I apply to any medication now. I think that that's a reasonable strategy. Understand that there are some medications that are incredibly hard to get off of. You might not be able to do that if you're taking Cymbalta or Lyrica. Those medications cause discontinuation syndromes. You have to work with your doctor on that. But for bladder builder, you could just slowly reduce the dose. Some people just do a maintenance dose of like 2 a day or 1 a day. So for anybody who doesn't know, this is Bladder Builder. New label. It's a chondroitin-based supplement. It's got chondroitin. It's got quercetin for the antihistaminic effect. Got some beneficial probiotics, and it has PEA in it for the nerve calming effect. So Bladder Builder is, in my opinion, the best supplement on the market. Especially for women with genitourinary syndrome of menopause. I think that that's like the perfect target for Bladder Builder. Hello, Kathy. Nice to see you. Hello, Leah. Leah says, what is Bladder Builder? Is it by prescription? No, it's an over-the-counter supplement that was created like 6-7 years ago. Hello, Chloe. Happy Sunday. Hello, Susan. Thank you for the 50 stars. So Leah, let me give you a little bit of context here. Back when I started with IC, the only supplement we had was Pre-Leaf. And in fact, you can see it on the shelf behind me, right there. Pre-Leaf has been a sponsor of the IC network from day one. They sponsor the ICA2, if I remember correctly. Pre-Leaf is a supplement that reduces acid in food. It was created by Dr. Alan Kligerman. I've known him for many years. He is now retired. And it is a product that you would only use before a meal if you're going to eat something acidic. It doesn't really do anything for the bladder at all. The next supplement that was created was aloe. And that was created by two sisters, one of whom had IC. And she said that aloe helped her, and they decided to create a company that focused on aloe. The challenge with aloe now, aloe has a soothing effect. So you would put aloe on a sunburn, right? So aloe in the bladder can have a bit of a soothing effect, but there's no research now that shows it has any beneficial long-term effect to the bladder. And let me, you know what? I always credibility test myself here. I'm going to go to the National Library of Medicine right now online, and I'm going to put in aloe interstitial cystitis, and let's just see nothing. I'll put aloe bladder pain syndrome. Nothing. Okay. And so aloe was very popular because it did kind of make people feel better. But again, now that we're phenotyping, now that we understand underlying causation, we're really focused more not on managing symptoms, but on identifying that underlying problem. So, but aloe helped many, many patients. It still helps some patients. We have it in the IC Network shop, as a matter of fact. We use it mostly for patients who are short-term use for a bladder wall flare. That's what I suggest for those aloe products. The next supplement that was created by Dr. Theoharides. It was called Cystoprotect. Dr. Theoharides was a major IC-funded researcher at Tufts University. The MD, excellent. He was an excellent researcher who also had a very, very strong interest in pharmacology, drug development. The state of Massachusetts asked him to investigate the safety of supplements online, which he dove into, had no experience with it at all. And as he dove into that research, remember, he'd already worked with IC. It was going, I wonder if that would help IC, and I wonder if that would help IC, and I wonder if that would help IC. And he decided it was worth a try. So he created the first chondroitin-based supplement, because the bladder lining has chondroitin in it. Chondroitin plays an important role in the superficial integrity of the bladder wall. And because he was a consummate researcher, he did a big 6-month study with over 250 patients that was published in the Canadian Journal of Urology. And a big chunk of those patients did well. They did better on it. And if I remember correctly, the patients who had the most severe symptoms appeared to do the best with a chondroitin-based supplement. So once he came out with Cystro Protect, he dominated the market. I mean, a very, very good product. But then there was an issue with the company that was distributing it put a cancer warning on it, which just was horrific at the time. And literally overnight, because the company never explained the cancer warning, we now know what that was all about. It's about titanium dioxide. It basically collapsed. For about a year, we couldn't get it. And so I went to another company, Natural Approach Nutrition, because I was getting so many calls from patients who were doing Cystro Protect and doing well, and I couldn't get it. I went to another company and said, can you please make us something like this? And they did. They made Bladder Builder. And what makes Bladder Builder completely different from all the other supplements is it also has an ingredient in it that calms nerves down, called palmitoyl ethanolamide. So Bladder Builder has been out now for about 7 years, 7 years, somewhere in there. And it now plays the leading role in most of the kind of supplement use online in our community, but there are variations. So we've had a couple of new things. So we now have palmitoyl ethanolamide, PEA, which is an ingredient in Bladder Builder, which we know from many, many research studies calms nerves down. So anybody who's struggling with pain, acute pain, chronic pain, surgical pain, IC pain, pelvic pain, prostate pain, shingles pain, fibromyalgia. I can give you so many research studies with PEA. In fact, there's a blog on the front page of the IC Network website where you can read all that research yourself. The latest study was with menstrual cramps and vulvodynia. So PEA is the game changer, because here's the deal. You can't get pain care right now. It is very, very hard to get pain medicine. And so what are we going to do for pain control? Well, when the European PEA researchers brought their study and presented it to the American Urology Association, it was at a meeting in Chicago, the doctors were ecstatic that they could now suggest something for pain that was not an opiate, has no risk of addiction, with no side effects in the IC study. And now that we're phenotyping, PEA makes the most sense for patients with widespread pain or just kind of pain in general, because it calms the nerves down, which are driving some of that pain. So that is called, here. Now, you guys, I had nothing planned for today, to be quite honest. So I'm riffing here. Feel free to ask any questions you have. So here you go. Here is one PEA, and then here's another PEA. So these are the two PEAs that we usually refer people to. I take this one because this was the first one that was on the market, but this one's just fine too. So we got two options. This one has great reviews. And for patients who are super, super sensitive, you don't like to take supplements, you don't like to take medications because you don't know how your body's going to react to that. And because God knows, if you're in the widespread pain group, you have an incredibly sensitive nervous system. We have Bladder Rest, which is a kind of a clean, pristine formula without a lot of extra ingredients. Okay, but here's the other big game changer: lactoferrin. So 2 years ago, researchers from the University of Italy published a paper using lactoferrin for patients with interstitial cystitis. And in fact, here is our new bottle. This is a brand new bottle. Okay. So let me explain this. What is lactoferrin? Lactoferrin is a protein found in colostrum. Your body makes lactoferrin right now. It is in your tears. It is in your vaginal secretions. It is a front line of defense for our immune system. It has natural antibacterial, antifungal, and antiviral effects, as well as an anti-inflammatory effect. The reason why it's the critical protein in colostrum, which is the mother's milk that goes to a baby, is it's building the baby's immune system. So lactoferrin is about as natural as you can get when it comes to helping your body fight off disease and infection, because it's how your body normally does it in the first place. But here's the problem. Our body's ability to make lactoferrin can change and it can diminish. Sometimes it diminishes with aging, sometimes it diminishes with other conditions. So for about the last 20 years, they have been testing a lot of lactoferrin from cows on humans to see if it would help fight human disease. And it turns out it does. It turns out it does. And so 5 years ago, this research team, again in Italy, was testing lactoferrin with recurring bladder infections. And they found that when you boosted your immune system with lactoferrin, that your body's ability to fight off infection improved dramatically. Then they decided to do IC. And that study was amazing. 31, now it's a smaller study, only 31 patients. What they did is they looked at the bladder before and after treatment. They mapped out any Hunner's lesions. They mapped out what the bladders look like. They measured systemic inflammation with blood testing. And then the patient basically took lactoferrin for about 5 to 6 months. And then they went back and looked at their bladder. And do you know that red inflamed bladders became pink and healthy? Hunner's lesions almost completely disappeared, and 28 out of the 31 patients had no symptoms or flares afterwards. This was so incredibly exciting to see, because we've never had something that would help a Hunner's lesion before. And so I was a week post having a double mastectomy. I read it and I was reading this study going, impossible. Like, it's got to be the pain meds. I'm not reading this right. So I shelved it for about 2 weeks because I had to recover from my surgery. And then I came back and I dove into it and like, oh my God, the research with lactoferrin is solid. I think it's very good. And in fact, there's a blog on the front page of the IC Network where you can go read all that research yourself, okay? And then I tried to bring in the Italian form of the lactoferrin, but there's all these import fees, and the company has to work with the U.S. government and go through various steps to bring it in. They thought I was going to pay for that. Obviously, I didn't have the money to pay for that. So instead, I went to Australia, where I got an Australian lactoferrin, which is considered the best lactoferrin in the world. The challenge with Australian lactoferrin is it's very expensive because we have to import it. Now, I will tell you that the very first phone call, and I've now had many phone calls from patients, very first phone call I had was from a woman who'd been on it for 3 weeks. And she had gotten up every hour for the last 10 years at night, every hour. And she called me and she goes, "You're not going to believe it." And I'm like, what? Tell me. She goes, "I'm sleeping 3 hours now." She said, "Jill, I haven't slept 3 hours in a decade." And she went and took a 2-hour car ride and didn't once have to go to the bathroom. She said, normally I'd be peeing every 15, 20 minutes in the bathroom. So she was like, "Hey, I think this is helping me, so I'm going to give that a shot." Now, obviously, it's not helping everybody because we're all different. We have different phenotypes, but especially for those patients who have a lot of inflammation in their bladder and or Hunner's lesions, before you're considering a more aggressive therapy, like somebody in one of the groups that I was reading last week was considering, her doctor had said, "Yeah, maybe we need to take your bladder out," because what was crazy is he'd only cauterized lesions. He hadn't done a steroid injection. He hadn't done cyclosporin. He had like jumped way over to bladder removal. And I'm like, no. Our guidelines don't say that. Our guidelines say, number one, cauterize, number two, steroid injection. And usually it's steroid first, then cauterize, because steroid injections don't leave scarring. Cauterization does. And for patients who don't respond to, or their Hunner's lesions are resistant to responding, their next step could be cyclosporin. And cyclosporin has some doctors call it a miracle drug in the way that it can really help the bladder heal for patients with Hunner's lesions. Not everybody, right? But as I said, listen, before you go for the big time stuff with the big risk, let's try the easy stuff first. And lactoferrin would certainly be one of the easy things. And we certainly have research to support its use. Just go right on over to icnetwork.org and you can read that research study for yourself and see what you think and see if you think it's worth it. So what I did, listen, the lactoferrin from Australia is like really expensive, $74. I had a lot of patients calling saying can't afford it. I went to, again, Natural Approach Nutrition, which I love this company, said, can you please give us a more affordable lactoferrin? And they did. And this is $25 cheaper. So now there's one that's much, much better. It's like $49. I was hoping I'd get it for $39, but times are hard right now for all these factories. So I got $25 off. So that's good. So anyway, and it's not just this redheaded woman online saying you can try a supplement. Actually, if you go back to the American Urology Association guidelines for IC, especially the 2008 version and the 2011 and 14 version, they actually encourage supplements first because they don't come with the risk of side effects that some of the traditional medications do. And as you're thinking about treatments, the goal is do no harm. Let's not do something that could cause irreversible damage first. My first year when I went to my doctor, and this is an example of how desperate you get when you're in pain. And my first year was agony and I had no pain care. I begged my doctor to take my bladder out. To take it out. I don't need it. I don't want it. Take it out. And Dr. Klein, the wonderful Dr. Klein, he said, Jill, I'm not going to take out your bladder. You haven't done any of the treatments yet. It's like, well, good point. Yeah, I really hadn't. And I'm so glad I didn't. You can't let desperation drive your treatment decisions. But as you're pondering treatment, rule number one is do the easy stuff with fewer side effects than doing the more dangerous thing that might have irreversible side effects, such as Elmeron, which is the only approved oral medication for IC, which is now linked to blindness, retina, pigmentary maculopathy, blindness, inflammatory bowel disease, and colectomy. So again, if you have to choose between a medication that does that versus a supplement where there were no side effects in the IC study and it literally red inflamed bladders became pink and healthy, it's like, maybe I might want to try that first. In the end, it's all up to you and your doctor. My job is to open up some new doors and windows, give you some new things to think about, to teach you about learning about things in a different way, approaching this in a different way, because there are so many patients, again, like I started this meeting, whose doctors are treating IC out of old textbooks, and it's like, listen, I got nothing for you but Elmeron, but GMSO. By the way, guys, okay, like a lot of research came out this week. Oh, hello, Karen. Karen is 58, diagnosed when she was around 20, in pain my whole life. Burning. I don't even know where to start. Could early sexual trauma have caused any of these symptoms? And the answer is absolutely, Karen. Absolutely. And you are not alone, my friend, at all. At all. So we have different types of patients. The IC is what we call heterogeneous. We're not all the same. Because remember, some people are diagnosed in childhood. Some are diagnosed after menopause. Same name, but are we the same? Of course not. Some people are diagnosed after they're going through chemotherapy because the chemicals of the chemo damage their bladder. While for others, IC begins after they fall on their tailbone. Again, same diagnosis, but we're really not the same. Today, IC is considered a pelvic pain syndrome, and there are distinct patient groups, and each group has their own treatments. So group number 1, Hunner's lesions. Okay, Hunner's lesions are big bloody wounds on the bladder wall that are known for bleeding a lot that have now been connected to viral infections. So when you're thinking of infection, don't just assume bacteria. We're now finding viral infections in the bladder. We're finding fungal infections in the bladder. And you know, it's so interesting. Gosh, I was corresponding with a doctor at UCLA. No, was it USC or UCLA? Like 6 weeks ago. And she said, well, lots of children get viral bladder infections. And I'm like, what? What? I've never heard that before. And it's like, what do you do about it? She goes, oh, they just go away. I'm like, wow, okay, but it's a lot we're not learning. I mean, a lot we haven't learned about this, obviously. Okay, group number 1, Hunner's lesions. And if it is driven by a virus like Epstein-Barr, which we have found in the urine of patients with Hunner's lesions, that explains why typical therapies don't treat it. It explains why it comes back, because it's a virus. Okay, there's another couple of causes, but that's like the big thing that we're looking at right now. The next big patient group is bladder wall driven without Hunner's lesions, and we're going to look for chemical injury of the bladder. So these are the patients using ketamine, going through chemotherapy, or drinking way too much Diet Coke or Mountain Dew or anything really strong and acidic to their bladder. The bladder is not impermeable. You keep pouring acid on it, eventually you're going to hurt it. It's going to erode. Second thing we're going to look at in this group is estrogen atrophy, the quality and health of your skin. And the thing is when you're 20, usually your skin's pretty healthy unless you're on a lot of birth control. That could put you into an early menopause, which can potentially affect your bladder. We're going to look for chronic infection, although there's a lot of people online saying everybody has a chronic UTI. No, absolutely not true. It's a tiny, tiny percentage of people who might have a chronic UTI, because most patients, 87%, okay, 87% of patients have tight pelvic floor muscles, myself included. So these patients, they need to be in physical therapy. Listen, if you can't release urine, if you have pain with intimacy, if you have pain when you're moving your body, if you have pain when you sit down, that gets better when you stand up. Those are all signs that we've got muscle issues going on. If you got the pain on the left side, you got pain on the right side, anything at all like that, that's pointing to things other than your bladder. We're going to look for positional pain. Does a patient have pain when they sit, get better when they stand up? If you have a history of sciatica, if you have PGAD, that's a sign that tight pelvic floor muscles are squeezing nerves. That's a distinct patient group. But our last group is where you might fit, honey. That is the widespread pain group. So these are patients who have multiple pain conditions, IC, IBS, or vulvodynia, or TMJ, or migraine. So I'm in this group. So I have IC, I had IBS, I had vulvodynia, I absolutely have very active TMJ, I had migraines for a while. These patients have very sensitive skin, wicked sense of smell. We smell things that other people can't smell. Smells drive us crazy. Sometimes we're light sensitive, sometimes we're sound sensitive. It's sensory. It's sensory. So, and when you're the patient, you're like so confused. Oh, and I should say too, anxiety, big time anxiety disorder. I had terrible anxiety disorder in my 20s and 30s. I still have anxiety fairly frequently. Very controlled now. I know what to do, but anxiety has been a big part of my life because of early trauma. So we have a fabulous research team called the Chronic Pain Research Alliance that was put together about 20 years ago, their job was to try to figure out why this happens. Why do some children grow up to have all these multiple conditions while others don't? and they started studying our nervous system. And what they found is patients who have multiple pain conditions, our brains are behaving as if we're in a constant state of fight or flight. The 24 hours a day, 7 days a week, our brain is behaving as if our life is at stake. And the problem with fight or flight is that it sensitizes everything. It amplifies everything. Listen, if you have pain and you are also anxious, your brain is going to intensify that pain simply because you're anxious. Pain that is accompanied by laughter is minimized the brain because the brain perceives that there's no threat. So it's a brain, it's a nervous system that is behaving as if you are under threat. Now, what the research shows is that for 80% of the children who grow on to develop multiple pain conditions as an adult, it is a major physical injury. I've worked with patients. I'll never forget a gentleman who called me who was in his 50s who was run over by a bus or a car when he was a kid, crushed his pelvis, had icy ever since. I mean, incredibly sensitive bladder, bowel, skin, nervous system, everything. I worked with one lady who broke her back in high school. Mother didn't believe her, sent her to school for 3 weeks with a broken back before they finally found it and got her treatment. 14 days of pain will put the brain into a constant state of fight or flight. So we see lots of injury, lots of big traumas. I was working with a patient last week whose foot was run over, and she was in the hospital for a month because it took all her skin off of her foot. And she had to have all these reconstructive surgeries. And she is in this group too, if I remember correctly. For the other 20% of us, it's a history of abuse or trauma. And sexual trauma is about the hardest thing a patient can go through. And I'm so incredibly sorry, Karen, that happened to you. Not your fault. You've done nothing wrong. You should carry no shame, no blame about any of this. You were hurt. And in the end, it's really about how does a child's brain respond to trauma, especially persistent trauma. So one of the themes in my office are people who grow up with alcoholic parents, a violent alcoholic parent. And I'll never forget this one patient last year or the year before who said she would take her younger brother. She was a child. And when dad got home and started drinking, they would lock themselves in the bathroom because they knew he was going to get violent, and he would break down the door and beat them anyway. And she lived her entire childhood like that. So, and she absolutely was in this widespread pain group. Now, there is good news here too. There's very, very good news here, because now we know what we have to target, which is the central nervous system. We've got to bring that central nervous system out of fight or flight. And it's actually pretty easy to do. And I can teach techniques. I work with a lot of patients on the phone. I'd be happy to walk you through a number of techniques that will do that. Another thing that's incredibly important is you got to get some control over that anxiety. I had terrible panic attacks for many, many years, especially before going to a doctor, because I felt like I was being hurt by the doctor. And even with a master's degree in psychology, I still panicked before going to the doctor. And finally, one day I was just like, clearly, I didn't learn something I needed to learn. And I signed up for a class at my local hospital that completely changed my life. And I have not had a panic attack since I took that class when I was 35, 30 years ago, because it taught me about fight or flight. And so I'm happy to talk about that, share the tips that we learned in that too, because in the end, we're adults now, and we have to teach our brain that it doesn't need to be afraid anymore. There is a fabulous method called EMDR therapy. EMDR therapy does a really good job kind of reprogramming your brain out of that trauma response into a response that's more healthy for your body in general. So, please feel free to call me. You can see my phone number right back there, 800-928-7496. No charge. Feel free. I have great videos on anxiety over on the IC Network website that I filmed that talk about the class that I took, but I'm really happy to walk you through stuff too. It's not a problem. Some people say, why do you do this, Jill? Oh, really easy answer. Because I had no help back then. And I always say, don't suffer in silence. Believe me, I suffered in silence. And about my trauma, I grew up in a neighborhood with a kid who became a rapist and murderer. I was attacked in 4th grade. I was attacked many, many times by this very mentally ill kid who became an adult who then, the year I went away to college, raped and murdered my neighbor. And I can tell you damn well, if I'd been here, it would have been me. I was a favorite target. And you carry that trauma with you. And I realize now, every decision I've ever made in my life, it's all about being safe because I was so traumatized by that. So anyway, I'm happy to talk about that a lot more. Hello, David. It's so nice to see you. Hello. Leah says, you may have covered this before. I'm new to your site, but my question is, how much blood in the urine is actually acceptable for IC and for how long? It's been a trace forever, and that's never bothered me, but for the last year, it's been consistently moderate amount. And not only am I having a hard time getting the doctor to figure out what's causing it, they just blame it on IC. Or they tell me I'm crazy, and I don't seem to think it's important to stop it. Okay, now, interestingly, our latest national guidelines take what we call hematuria, blood in urine, or microscopic hematuria, where you can only see it under a microscope. They're taking it much more seriously than they used to. And they want doctors to do an appropriate diagnostic workup to make sure that other conditions such as bladder cancer have not been missed. The number one symptom of bladder cancer is blood in your urine. So if you can see blood, like you're peeing pink or you're passing blood clots, that is urgent care. Urgent care or the ER. This is not something that you stay at home with. If you are peeing bright red blood, you get your tush over to the doctor or the hospital right away. Now, the easy thing here, Leah, is that your doctor may have already checked. There is a urine test called a urine cytology, where you just pee in a cup and they look for cancer markers. And if they find it, they'll let you know. The number one risk of bladder cancer is smoking. So if you were a smoker and you've got blood in your urine, you need to ask for a urine cytology. My doctor did it automatically because my mom was a smoker. In fact, my mom smoked when she was pregnant with me, which it's like, wow, why would you do that? But again, she grew up in the generation where they were all told smoking was safe, and she got very, very addicted to it. We know now smoking isn't safe. She would never have done that if she knew that. Anyway, that said, I was exposed to a lot of secondhand smoke when I was young. And so it was very important for them to check to see if I had any cancer markers. And also, the good news here is if you do have bladder cancer, it's considered the easiest cancer to treat. But we don't know. And I don't want you to catastrophize. Listen, I thought I had cancer for a year when my symptoms started. I didn't believe anybody when they said I had interstitial cystitis. It's like, I feel like I'm dying. I must have cancer. So much so that I demanded exploratory surgery, which was done in September of 1993. And I remember my doctor in the recovery room saying, we found nothing. You're not dying. It's not cancer. you got icy. So that worry about cancer is a real worry. But this is an easy thing to check. Just go pee in a cup and let them look. The odds of it being cancer are tiny. That said, if you feel like you're peeing, if you're seeing visible blood, you need to go get it checked. I'm saying that as a breast cancer patient, because the earlier you catch cancer, the easier it is to treat. If you let it go on and on and on, it can grow and metastasize. So man, you got to nip that sucker in the bud. Carlene said, what bladder builder do you use? I do not use any chondroitin supplement because my bladder wall is healthy. I do not have a bladder wall phenotype. I have the pelvic floor phenotype and the widespread pain phenotype. So I just take PEA on its own to calm my nerves down. I don't use a chondroitin supplement, but I'm getting closer because I now have estrogen atrophy and I'm feeling it in my bladder more. I do. I'm definitely starting to really feel the effects of estrogen atrophy, and it's annoying. Linda says, you're such a blessing to anyone with oh, thank you, honey. I remember talking to you decades ago when I was first diagnosed. Any thoughts on Lactobacillus reuteri yogurt-like substance from Dr. Davis? I've been making it for a few weeks. I do believe it's helping with my acid reflux. I'm pretty much pain-free right now. I do believe the lactoferrin is making a difference. Yeah, I'm so glad. Lactobacillus reuteri is one of the critical probiotics, a normal part of the human biome. So I don't have any problems with that. I don't know anything about Dr. William Davis. Hello, Sarah. Hello, Paula. Nice to see you. Hello, Kathy. Paula said, how long should I be taking amitriptyline for? Now remember, my job is not to give you medical advice. My job is to educate you and inform. So let's talk about amitriptyline for a moment. Amitriptyline is a low-dose antidepressant which acts to calm nerves down over time. It was the first antidepressant that I was given. And I took it for about 3 months before my heart started getting very weird. Amitriptyline is a tricyclic antidepressant that has a bunch of side effects that make it very, very difficult to get to a therapeutic dose. It can cause weight gain. You start to snack a lot. It can cause dry eyes, dry mouth. And what a lot of people don't know is that it can also affect the conductivity of the heart, which is what it did to me. I ended up having to wear a heart monitor for a month. You know how you have 2 nodes in your heart that control your heartbeat. You have the AV node and the SA node. So your heartbeat is beep, 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 beep. It turned on a 3rd node in my heart. Crazy. So my heartbeat went beep, 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 beep. And sometimes 2 would beep together. So it'd be a beep, 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 a really hard, incredibly scary heart rhythm. And yeah, so if your heart races when you take an antihistamine or a decongestant, like what's the name of that one that's known for causing irregular heart rates and tachycardia? Anyway, then amitriptyline is usually not suggested. But here's the other thing you need to understand about medications of that type and anticholinergic medication is it's also linked to cognitive decline, dementia. So generally now that once that research came out, and this is big research, valid, tens of thousands of patients in these research studies with this cognitive decline, there is no doubt about it. If you take it every day for like 3 years, apparently there's like a 50% risk of cognitive issues. And so generally, if you're over the age of 50, they don't want to put you on a medication like this because they want to protect your cognition. Instead, we would turn to another medicine. So that's a really good example of a medication that comes with pretty significant risk. I truly regret taking amitriptyline. Then they put me on imipramine and nortriptyline, and those were worse. My body does not tolerate this class of medications at all. And if I had known what it would do to my heart, I would never have taken it, because I now have 3 nodes in my heart that occasionally get a little bonky. It's calmed down a lot, but my heart is not the same because of the amitriptyline that I did. Then I got COVID, and that messed my heart up too. So, life. Instead, again, if we're trying to calm nerves down, it's absolutely worth trying, in my opinion, trying the PEAs first, because there's a ton of research studies showing this is safe and effective without the side effects. The therapeutic dose of amitriptyline is 75 milligrams, and in every class I've ever I've ever attended, like at the American Urology Association, they always say it's very hard to get patients to that therapeutic dose because of the side effects. Good luck. Probably not going to happen. And I also forgot to mention the weight gain. We call it the Elavil 20, because it makes you snack more. And then when you stop the med, you generally lose the weight. So I am not a fan of amitriptyline from personal experience. Hello, Kayleen. Nice to see you, girl. Hope you're well. Hello, Cindy. Cindy said, I've had IC for 40 years, but only within the last 3 years, I found out that I have tight pelvic floor. Yes, exactly. I know relaxing my pelvic floor helps, but it is hard to do since it's been that way for so long. Exactly. Your muscle memory is stuck in tension. My cystoscopy was normal multiple times, but Elmeron helped a lot for 20 years. I had to go off of it due to retinal damage and ulcerative colitis, but I must have bladder information, as diet was the only thing that helped. Now with a tight pelvic floor, I'm not sure what supplement might help. Okay, Cindy, so here's the piece that you're missing. The consequence of tight pelvic floor muscles. The problem with tight pelvic floor muscles is that they squeeze things, right? So they can squeeze your urethra, which would make it hard for you to relax enough to release urine. They can squeeze your vagina, which makes it very hard to have sex. They can squeeze your rectum, thus leading to constipation. But tight muscles can squeeze nerves. That's why you could have sciatica. That's why you could have PGAD. Okay, pins and needles, areas of numbness. Listen, I got some patients, there's some clients whose feet go numb when they flare because their muscles are so tight. They squeeze the nerves so hard, their feet literally go numb. But here's the piece that you're really missing. They also squeeze blood vessels. So if your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? It's impossible, because that tissue is being deprived of oxygen and essential nutrition. So the ultimate therapeutic priority for the pelvic floor patient is to restore a blood supply. That's why we do physical therapy. We got to get the blood flowing again. So that's why pelvic floor patients are diet sensitive, because your bladder just doesn't have enough nutrition and oxygen to be healthy. Once you do the physical therapy and you restore the blood supply, normally the bladder heals. I can eat anything now. Now that my muscles are in good shape, I drink lemonade. Hello, every day. Every day I drink lemon. I didn't drink lemonade for 25 years. I can drink it now because my bladder wall is healthy. So physical therapy is absolutely your priority. We have to listen, if you only have a limited amount of money, don't throw it at a supplement, throw it at physical therapy. And that you've got to ask the physical therapist, are my muscles responding to therapy, or are they always tight? If your muscles are always tight, we've got to figure that out. Because my muscles on my left side are always tight because my SI joint is funky. My SI joint moves too much, so my muscles lock down to hold the joint in place. For many patients, if not most patients, one of the reasons why their muscles are so tight is it's ultimately about how their foot hits the ground. If you got an ankle that rolls in, if you got an ankle that rolls out, if you got Morton's neuroma, if you got plantar fasciitis, that all points to a problem with how your foot hits the ground. And the problem is all those dysfunctional forces get reflected right back up your legs, right into your pelvic floor. So for anybody who's dealing with pelvic floor issues, here, where is it? This, my friends, is critical, especially if your muscles are always tight. Breaking Through Chronic Pelvic Pain, a holistic approach for relief by Dr. Jerome Weiss. Dr. Jerome Weiss was the first urologist back in the 80s who saw bladder treatments didn't work. And he wanted to figure out why. And he was the first mainstream urologist to embrace the pelvic floor. He was right. And again, now we know 87% of IC patients have tight pelvic floor muscles. They used to laugh at him. He was right. This book is amazing. It is filled with case studies. It is filled with patients whose symptoms presented in certain ways. He explains exactly how he treated it. And his, for example, bike rider syndrome. If you ride a bike, you can see exactly how sitting on a bicycle seat pushes right up into the nerves in your pelvis and the muscles of your pelvis. But what became the defining mystery of the latter half of his career before he retired was, why do muscles stay tight? That's what he wanted to know. And it was a podiatrist who helped him figure it out. And so let me show you this picture right here. This shows exactly why an ankle problem can screw up your pelvic floor. So here is a healthy leg. Okay, so this one over on this side. This is a perfectly healthy leg. It hits the ground at a 90-degree angle, right? The shin goes straight up at a 90-degree angle, and then you can see the femur has to go slightly to the side to connect to the hip bone. But look what happens when you have an ankle that rolls in. You've lost your 90-degree angle because now this foot is bowing out. I mean, the leg shin bone is at an angle going out, which gets exaggerated up in the femur. And if you look closely, you can actually see it stretching out the pelvic floor. You can see that. So, I love this book. This is everything. Here you go. A 37-year-old woman had sudden unexplained onset of pain in her buttock and leg that radiated down to her heel. She began having pubic and vaginal pain, urinary burning, and rectal spasm. The symptoms suggested a lumbar disc herniation, a UTI, hemorrhoids, and colitis, but all these problems were ruled out with lab tests and with an MRI of her back. Dr. Weiss's internal physical exam revealed pelvic floor dysfunction, which turned out she had a short leg, SI joint instability, SI ligament laxity, which is what I have, and a tender ligament. An x-ray of the patient's pelvis confirmed this. So a simple shoe lift combined with some myofascial pelvic floor work fixed her problems. You can get this in the IC Network store. I think I'm down to like our last 10 copies, maybe. He did pass away a year ago. wonderful, humble, kind, sweet man. Oh my God. And he went to these big urology conferences advocating and trying to encourage doctors to learn about muscles. They blew him off. And you know what? He was right. And now everybody admits that. Yeah, Karen, I see what you wrote, and please call me. And you're not alone, girl. You're not alone. And anxiety is a big part of my daily life. It was for me too. Still is. I mean, I was walking today, and I kept myself. I had a couple of catastrophic thoughts, and I'm like, stop it. You're safe right now. There's no reason right now for you to worry about anything. It's just a brain and a central nervous system that's just trying to keep you safe. That's all. Stay home where it's safe. Don't go anywhere. That's a way, a trauma. That's a common way that the brain responds after trauma. And if your trauma is at home, then your brain's very focused on getting you out of that home. My safe place was my home. So my brain says, stay home. Other people, exactly the opposite, but it's still all a trauma response. Linda said she ordered the lactoferrin the first day we posted it, and she's doing great. I love it. Cindy said, I take amitriptyline for 40 years, metoprolol for heart murmur, omeprazole for gastritis, aloe vera, pumpkin seed, magnesium glycinate, did PT for a few months, diaphragmatic breathing. Yoga stretches, always worth it in the morning. The more active I am, the better. Still working as a microbiologist in a hospital lab. I'm 66, also on estrogen cream. Okay, so, Cindy girl, listen, I take metoprolol for heart issues. I take blood pressure medicine. I take thyroid medicine. I mean, you got to do what you got to do. What I would say, though, is there room for improvement with your bladder symptoms? If there's room for improvement, maybe it's time to think of it a different way. I don't see any benefit to long-term aloe use. I don't. I mean, would you keep putting aloe on a sunburn all day? I mean, then when the sunburn fades, we still put the aloe on it? Of course not. I think it would be a much more interesting and intriguing to try a chondroitin-based supplement, because chondroitin is, again, a building block of the bladder wall. So anyway, Brandon, hey, dude, how are you? I appreciate talking on the phone with me last week. I've currently got a raging sinus infection and asthma flare-up. I got doxycycline and prednisone for it. I hope to get, hey, man, I got to tell you, it's like every year we say this, but cold and flu season 2026, I think, was horrific. Absolutely horrific. And Kyle Busch, he passed away. So you got to take care of yourself, guys. And if you're having any issues, you go to the doctor, get the antibiotics, rest, stay home, drink fluid, don't keep working. I think the people who were managing Kyle Busch and had him working when he was so ill are to blame. Robbie says, a cyclosporin injected in the bladder. No, it's a medication. It's not put directly in the bladder. Linda said she too begged her doctor to take her bladder out. Yep. Here, hold on a sec. This is actually mostly water with a little bit of coconut water and a little bit of lemonade. All right. Kayleen says, my urogyno said that I have to continue the vaginal estrogen, but once a week instead of twice. I couldn't take the migraines, but I still need the estrogen. Okay, got to do what you got to do. And Kayleen says her offender's been in prison for the last 3 years. Well, mine has been in prison for the last 40 years. I don't even know if he's still alive. I don't want to know. I mean, it's so, now that we've gained so much insight into childhood trauma and how that can affect our bodies and affect our lives. And I carried so much, I'll be really honest with you. My identity, my fundamental identity, even at the age of 65, is a little redheaded girl running for her life. Because I was running for my life every day for years. And it was the other part of that is being alone and being very lonely because people didn't help. The kids didn't help because they didn't want to get beat up. They didn't want to get hurt. I understand why the kids wouldn't help, but the adults weren't able to help either because they just didn't see how bad it was, until finally he ended up committing crimes. I have never been able to shake that. I am still the little redheaded girl who feels left out. I am. And I see that very, very clearly. I know exactly what that's from. It is not my fault. This is how my brain responded to trauma. I would like to not feel left out so much. That's like my button. It's my button, feeling a little bit left out. Man, like if there's a family event and people forget to tell me about it, woo! I do not have a good reaction to that at all. I just really struggle with that. But at least I know it now, and I don't have to get upset about it. I understand it. I know why it's there and all that sort of stuff. Leah says the new urologist refused, and again thinks it's just IC and blood is normal. It's only after a cystoscopy she did. That's what's driving me crazy, that they refused to do any further testing to narrow down cause, literally gaslight me into thinking it's normal. But I think she ruled out cancer based on cystoscopy. That's the perfect way to do it. You may not be able to answer that follow-up question, but thanks for responding. I think I missed your follow-up question, Leah, so ask it again, girl. Ask it again. And thank you for the 20 stars. Linda said, you mentioned retiring in a few years. Hope and pray you are training someone to take over. Oh, I wish. I've got one person in mind that I think could potentially take over. But I don't know. Listen, this is my life. This has been my life for many years. I love what I do. I'm going to do it as long as I can do it. The only thing I want to stop is having to manage stores and technology. If I could just come talk to people over the phone and come online, do this, I'd be a very happy camper. But I'm not giving up yet. And they got the cancer early and I'm stage 0. And so Kathy said, another side effect of amitriptyline is breast secretions. It happened to me and I'm 76 years old. It scared me to death. Yikes. I didn't know that. Sandra said, Sandra Tom, girl, do you have somebody in your family named Jane? Because if you do, my mom and your Jane were friends. She always talked about Jane Tom in Carpinteria, California, if I remember correctly. Would physical therapy work for somebody with Hunner's lesions? No. Physical therapy was not going to heal a lesion. What physical therapy is going to do is relax the muscles that are tight because of the pain of the lesion, you know? But for the lesions, there are other things that we want to do first. I mean, lactoferrin for sure, because we got the research to back that up. If that doesn't work, cauterization, fulguration, or steroid injection. If those don't work, cyclosporin. Hi, Gay. Cheryl says, how many pre-leaf would you recommend someone to have before having a can of soda? Oh, that is a loaded question, Cheryl. Oh my, ooh, that is sneaky. Okay. If you had an open wound on your hand, would you pour soda on it? And the answer, of course, is of course not. You wouldn't pour Coke on an open wound or 7-Up on an open wound or alcohol on an open wound. Hello, it's going to hurt. So, would you pour soda with pre-leaf on an open wound on your hand? And the answer is like, no. You have to let your bladder heal first before you try something like that. So if you have Hunner's lesions, it's a hell no on any soda. If you got estrogen atrophy, if you've got any of the other bladder wall things where we're really focusing on, we want you to be off of the sodas and the coffees for like 6 months. You got to really help your bladder heal. The bladder is the slowest healing organ in the body. Nothing happens overnight. Nothing happens in a week. It takes 2 weeks for one cell to be repaired. And we just had a new research study that's talking about bladder healing, and they were saying it took 6 months for the bladder to fully heal. So I don't think you should be drinking any soda while the bladder's healing. But once the bladder's gotten better, the soda I would suggest that you do is going to be either an old-fashioned root beer, non-caffeinated, because it's naturally lower in acid, or make yourself an Italian soda with sparkling water and a little bit of flavoring. And it's 2 caplets will reduce like 95% of the acid in a cup, not a can. I think in a cup of soda. So not a fan of soda. I stopped drinking soda 30 years ago. I think I have had I hadn't had a soda in 25 years until my parents were dying and they were in the hospital, and somebody handed me a 7-Up and I drank it like a beast. So I had a couple of 7-Ups and then they died. And then I'm like, okay, I'm not doing the soda anymore. So having that little bit of extra sugar was meaningful at that time. But, cancer grows with sugar. So the last thing you're going to see me do is eating a lot of sugar right now. Cheryl says, I had Botox shots 2 weeks ago, and I've slept almost every night with minimum pain. Good, because Botox silences nerves. So good. Erin said, you look pretty today. Aw, thank you, honey. I started generic Wegovy a week ago. I'm constipated and in the worst flare. I'm wondering if anybody else has experienced this on a GLP-1. I have discontinued it. Of course, I don't know. I haven't had anybody call me no, I take that back. I had one person call me. Who had a really bad reaction to a GLP-1. I did. Like 3 months ago. I don't remember what their symptoms were, though. Katie said, me too, horrific childhood trauma. I'm 70, a retired trauma therapist, but I'm still carrying that identity as well. Yeah, it's just so interesting. I mean, I can look at it academically now, Katie. I mean, I recognize it for what it is. And honestly, I like that little redheaded girl. I like her. I love her. I love that that she made it, that she survived all of that. I'm proud that that little redheaded girl was able to save her own life, but it's the long-term ripple effect of trauma that I think is interesting. I lost a lot of my friends I had trouble making friends. Well, I did, but I didn't. I have trouble trusting for people who want to be friends because I really felt betrayed by my friends who did not help me when I needed to be helped. So trust is a big issue with me. Oh, I don't even know. I don't even know how to put it into words, I mean, it's okay to embrace ourselves. And Katie, hey, would you like to write an article with me? I would love to do something. And so like I'm building this whole new section of the IC network. Yeah, okay. And so what we're going to do, so everything's going to change on the IC network, especially on the front page. Oh, great. Oh, Katie. Oh, that excites me. That would be so cool. What I'm going to have, and I'm working with a programmer on this, is literally when you go to the front of the IC network, there's going to be like 6 patients, like 6 little case studies. And you have to click on the one that reflects you. And then that takes you into their story. So we're going to have the young child who develops symptoms. We're going to have the teenager or the early 20s that's going to have that had symptoms. We're going to have the male athlete. We're going to have the pregnant woman. We're going to have the menopausal woman. And so what I'm doing right now is I'm doing so much right now. Is I'm like writing up like mini case studies of each one. And it's just meet an IC patient. And we're trying to bring in a little bit of AI on the back end so that you can talk to them. Wouldn't it be great to talk to another patient? I mean, I know that's why people call me. So many people call me and they're like, you're the first person I've ever talked with. And so, yeah. Katie, my email is icnetwork@mac.com. Would you pop me an email? And I will call you this week. Or I will email you this week. Because this is an estimated 40% of IC patients fit the widespread pain phenotype. And literally every single day I work with a trauma patient now. And I'm really good at what I do. I do have a master's in psychology and I've done a lot of training. Oh, great. Let me write that down. Hold on a sec. But I just feel like there's more that we can do. And even more so, man, I want to dive into having a really good section on techniques that people can use to reduce anxiety and trauma. And anxiety far beyond cognitive behavioral therapy, which turns people away. People don't want to do that. I want to focus on really clear, practical tips that a patient can do while they're watching this. I have a lot of ideas there. So let me write this down. Hold on. It's Dr. Ken Peters who's one of our top IC researchers in the world. He's at Corewell Health, formerly Beaumont Health, outside of Detroit. He did the first study that assessed sexual trauma is a history. How many patients have a history of sexual trauma? And if I remember correctly, it was roughly like 30%, which fits in line. The 40% we think have the widespread pain. Okay, you are on my list to do, Katie. Thank you, thank you, thank you. Ooh, I'm excited. I'm excited because I really love your feedback on what's missing. You know, I like people who tell me what I'm doing wrong. The people that I respect the most really are the people who say, Jill, have you considered this? And I like to be challenged in a way, and I don't want to be insulted, but I like to be challenged. And I know you wouldn't do that, but other people have done that. I just think that 2 minds, 4 minds, 6 minds, 8 minds working together, 20 minds working together are far more effective than one. Kayleen tells Aaron I was on Victoza and dealt with the constipation, even ended up in the ER a few times with severe abdominal pain. My GI told me just to take Miralax every day. I had to strictly stay on healthy foods. The macros were 90 grams of protein and 25 grams of fiber a day. Girl, you were doing it. I will, honey. I absolutely will. And if you don't hear from me, you email me back. Listen, my policy is I want everybody to be the squeaky wheel in these meetings. If you try to call me, if you try to email me, you just got to understand that, like, it's not that I'm distracted. I'm really not distracted. I'm very, very focused. Some days I'm on the phone for 8 hours. And then my voice goes bad, and then, you know, it is what it is. So if you don't hear from me right away, email me, call me. It's okay. Please do. Just please do. All right. Let me go back to YouTube here. Karen said, weird question. These tight muscles you're talking about, can RLS be a part of that? I was diagnosed with that only a few years ago. I'm up many nights from the pain of how tight the leg muscles get. So restless leg syndrome. I don't have a statistic for you. I cannot tell you how many patients have restless leg syndrome. I will tell you that many have reported that. And even I have moments every now and then where my legs are kind of moving all over the place too. But it's about pelvic floor relief for me. So it's common. I'm going to say it's common. Do we know why? No, I think one thing that could be happening is just for the older patient, the estrogen atrophy patient, menopause causes all sorts of really random things to happen, including a lot of leg cramps. I get a ton of cramps in my shins and in my toes. And I take magnesium glycinate too. And I've talked to my doctors about it too. And it's like, you know, it's one of the things that kind of happens when you go through menopause. Who'da thunk, huh? Who'da thunk? This whole getting old thing is very weird. Very, very, very weird. Okay, so thank you, Cheryl. Darla says, Jill, I thank God for you. I have come so far. I don't need doctors with suggested installations or Elmeron, which I fought 4 docs for. When you just said childhood trauma, yes, I did make it. I'm crying. What a relief I was in the hospital from my abuser at 3 years old. I felt so unseen, to be beat until 14 years of age, until leaving home to be married. And then yeah, that's very common. Now I understand my IC, avoiding stress, letting go. I have come so far. I'm so excited for my future. Just have a lot of work left to do. Thank you. Thank you. Thank you. You're well. You know, honey, you got to understand, I didn't understand what I was going through. I mean, I'm not lying when I say that when I was in my late 20s, I was severely depressed and just watching the world go by. I mean, like I live in the same home that I lived in back then. I inherited it from my parents after caring for them. I'm very grateful for that. And my home is my refuge, and my home is also kind of a prison in a way, because I want to be away from my home. And I do get out a lot now. But for many, many years, I was just laying on the bathroom floor, or I'd be up in the middle of the night laying in the living room in the fetal position, crying my eyes out in pain. And then I'd run to the bathroom, and I wouldn't flush the toilet because I didn't want to wake people up, but I would just run to the bathroom every 15 minutes. And, you're just so confused, especially if you have multiple pain conditions, because you feel like, it's like, God, really, every year you're giving me something new. First, it's my vulva, then it's my bowel with IBS, and then it's my bladder, and then it's the migraines. It's like, am I being punished in some way? And I legit, for a couple of years, thought that I was being punished. And I even thought, maybe I'm just not a worthwhile person. I truly, I even stopped eating with my family because I didn't think that I deserved to eat with them. Straight A student, presidential fellow. And yet that's how I felt on the inside. And I didn't talk about it until I was like in my 40s, to be quite honest. I don't think I even understood how severe that trauma was. But there were the first glimmer. There were a couple of glimmers that finally gave me context. The first glimmer was when the nerve research started coming out. And it started explaining what we call pelvic crosstalk or neural crosstalk, that the nerves in the bladder communicate with the nerves in the bowel, and the nerves in the bowel communicate with the nerves in the bladder. They called it the pepperoni pizza algorithm. You irritate the bladder, or you irritate the bowel, the bladder's going to get irritated. You irritate the bladder, the bowel's going to get irritated. So we started looking at anatomy. We started looking at nerves. And I'm like, okay, that's definitely me. Then University of Maryland started doing some genetic research. And I knew that my mother was very sensitive. She was diagnosed with honeymoon cystitis. My sister was very sensitive. So it's like, okay, maybe we've got some genetics at play going on here. And of course, we have no control over our genetics. So it's like, okay, definitely not my fault. Redhead, a lot of nerves. Redheads have 30% more nerves than everybody else. I don't control that either. And then there is this, so here I am just in agonizing pain. Driving a mile was like driving 100 miles because the car hurt so effing much. Of course, now I know why, because it was all pelvic floor driven. But anyway, I went to this little store that was only there for like a year. It was like a book on tape store before we had iPhones. And this little Apple doll of a woman ran the store, and I walked in, and she looked at me, and she saw me, and she saw that I was not doing well, that I was suffering. And she handed me she said, I've got 2 things that will help you. And she gave me a book on guided relaxation, or not a book, an audio tape. It was Potentials Unlimited Guided Relaxation to try to help me sleep. And by golly, it did. I trained myself to fall asleep. So no longer was I up a lot. I could now fall asleep with this guided relaxation. And we have guided relaxations for free on the IC Network website, by the way. And the second thing that she gave me was Norman Vincent Peale's book, The Power of Positive Thinking, but it was a tape, right? And normally I would like, I don't want to hear any of that. But, you know, she just said, I promise you, just listen to a little bit of it. And one of the things that Norman Vincent Peale says is, if all of your thoughts are negative, you become a self-fulfilling prophecy of negativity. So if you assume every day it's going to be a bad day, that you're going to be in flare every day, that this doctor's appointment is going to hurt, if you are going to be rejected, whatever. If you allow your brain to live in that space constantly, we call that catastrophic thinking or ruminating. They both apply. You're not giving your brain a place to go. You have to tell your brain where you want to go. You don't want to have a bad day. You want to have a good day. You don't want to fail. You want to succeed. And he talked about affirmations. And so an affirmation is something you say to yourself to empower yourself. So I've got like 4 affirmations that I've said almost every day to myself, which is, I can do all things through my faith, which strengthens me. Every day in every way, my life will get better. My favorite affirmation by far is, be bold and mighty forces shall come to thy aid. And there are more, but those are like the 3 that come to me the most frequently. So anytime I'm facing something that's uncomfortable, or if I'm going to the doctor again, it's just like, be bold and mighty forces will come to thy aid, Jill. Just be bold. Just do it. You can do it. And what he had us do is write them down on postcards and carry them with us. And I did that. And I wrote them on a spiral postcard thing, and I colored it. Man, I learned it. I committed. I memorized. And it was amazing how that changed my outlook. I used Post-its everywhere in my house, and I put positive messages everywhere. I can do it. I am loved. I am worthy. And you can see kind of back there, I still have, and you can see up on the wall back there, I've got a lighted love sign. I mean, I live in the light. I do not live in the dark. The drapes are open. The sun is shining in. I got plants. I got colors. I am purposely, with great determination, living in the light. It's nobody's responsibility to make me happy. It is my responsibility to make me happy. It is my responsibility to do the things that I need to do to be happy in this life. And kind of like one of the lessons learned is, sometimes you think you're waiting for other people to do things for you because you're in pain and you want to be rescued. I wanted to be rescued, but in the end, we have to rescue ourselves. We have to pick up the phone and call the doctor. We're the one who opens the pill and takes the pill. We're the one who does the treatment. We're the ones who get up and walk outside. We're the ones who turn off the internet and go do something better. I didn't understand that when I was in my 30s, even my 40s. I really understand that now. I was waiting for other people to fix me. You can't do that. You know, you get to decide, how do I want to live this life? And it's hard, because sometimes that means you get to step away from people who are hurt you know. But anyway, I'm just having a lot of revelatory thoughts these days, now that I'm feeling so much better and kind of over the trauma. This is my 2-year anniversary of being diagnosed with breast cancer, like literally right now. And that was just so life-changing and so traumatic, and to go through the surgery, and, you know, the girls are gone, my friends. The girls are gone. You want to know the funniest thing about having a mastectomy? You want to know the funniest thing about having a mastectomy? When you look at yourself from the side, like, you're flat, right? There's no boobs, right? And for the first time, you see a fat roll that you never in your life have seen before. It's like, whoa, wait a second. Where did this fat roll come from? I've talked with other kids. It's like, whoa, wait, I have never seen this structure in my life, but there is fat there. And now it is my mission to try to get rid of this inch of fat. There it is. It's right there. The breasts hit it. You gotta look for it. And you know, guys, listen, humor is so important. And you have to look for the funny moments of life with IC. And God, one of the funniest stories I ever heard from another IC patient, her name was Patty. And I don't know where she is now. She was really big. And we used to have a chat room back when we had chat rooms before the lawsuit shut down all of our chat rooms. So we had a really, really big chat room. It was open every night. And there was a big group of patients who would come in, and we would all hang out and talk to each other. And Patty just kept having the most random, weird things happen to her. And the crazy thing happened when she stopped at a gas station to use the bathroom. And you know, everybody knows gas station bathrooms are the worst. You know, I mean, you have no idea when they've been cleaned. The sinks are dirty and stained. The toilets are dirty and stained. The floor is just like, oh my God, I don't even want to know what's on the floor. It's sticky. Oh my God. So she went into this bathroom desperately because of a flare, and she peed, and she got locked in. She couldn't open the door. And she banged and yelled, praying they just couldn't hear her over, you know, all the sounds of the mechanic in the gas station, and nobody came in, and she's, you know, hanging on by a thread. Oh no, somebody help me. And then she's like looking at the door and looking at the floor going, I can do it. I can do it. I can do it. I can get on my stomach and shimmy underneath this door, not knowing why the floor was as filthy as it was. And you know what she did? She got herself out. And she was horrified. I was playing a tennis tournament, and I was on center court. I was on the center court, and I got locked in the bathroom off the center court, and I had to bang on the door. It's like, I'm here. They were going to default me because I wasn't there, and I was like 10 feet away, stuck in the bathroom. So you just have to look. Everybody has funny moments. You know, like if you're at the local park and you need to pee and the bathroom's too far away and you could go right behind that tree, you can do it until you have an encounter with poison oak, you know? You got to remember that, but it's okay. I mean, this is life. There are good things and there are funky things. Thank you, Abby. Thank you. Abby says, it feels impossible sometimes. It does. You know, I, um, I had a tremendous amount of anger in my 20s. I mean, I was just so angry that I was in pain, and I was so angry that I wasn't able to date. I was at home in the bathroom, and it was kind of eating me alive in a way. I mean, I never took it out. I tried never to take it out on my family members. I took it out a couple of times on my mom to my immense regret, my immense regret. And, probably over our lifetime together, maybe 8 or 10 times where, I mean, she once slapped me. I mean, she slapped me across the face when I was a kid because I mouthed off at her, which was, I always thanked her for it, but because that woke me up that I was completely mistreating her. But anger makes you say things you would never say if you weren't angry. And so I realized that I had to have a much better way of expressing that anger. And so I started journaling. And I have my journals. And my rule was 3 pages longhand before I got out of bed in the morning, just like get all the anger out now so you can have a good day. And then 3 pages before I went to bed, get it all out now so I can sleep that night. And journaling, and the rule is you don't read it again. And the entire point is to get it out of your soul. You just have to let it release. If you're consumed with anger, you just kind of spin in a circle like this. And I could sense that I was doing that at a pretty young age. And so it's like, nope, I'm going to nip this in the bud. So I started journaling. I started working out. I was working out more aggressively, and I would allow myself when I was swimming, it's like, okay, swim in anger lap. You want to be angry? Go for it. Hit the water as hard as you can. And I would do that. Legitimately, I would do that. I do that for a lap or two, and then I get tired. It's like, okay, swim a happy lap, or just be mellow again. Just finding a way to release it constructively. It's really, just really important for your sanity, because you don't want to be the person that kicks the dog. You don't want to be the person who mouths off to a child and makes them cry. And you don't want to abuse your partner or your spouse, which you can do when you allow that anger to build up. We want to be remembered as the kind person. We don't want to be remembered as the angry one. And so that was, Abby says, journaling is a great idea. Yeah. Abby, listen, I started doing that right around your age. And I got to tell you, girl, and again, you don't read it. You don't have to read it again. In fact, it's better to burn it. Have a ceremonial burn once a week. Okay, but you girl, listen, you just gave a giant clue. You say, every time I exercise, I'm in pain afterwards. That's exactly how I was. Because I was an athlete. I was a big athlete when I was younger. And I went to the gym and I would swim to manage my stress. I was never a group sport person. I was the individual sport person. And I felt so good when I was swimming, or just, finding peace that way. But when my IC started, I kept doing that. And it was my family who said, don't you see how worse you are after you work out? And I'm like, no, I'm on an adrenaline high. No, they're like, every single time, Jill, every single time you go do that, you hurt yourself. And the light bulb finally clicked when the muscle research came out, because I have a perfectly healthy bladder. There is nothing wrong with my bladder. My pelvic floor is a mess because I broke my tailbone when I was young. That's a huge reason why exercise used to hurt me so much. So when movement makes your pain worse, Muscle girl, we got to look at those muscles because your bladder's not going to do that. Your muscles are going to do that. Have you had a pelvic floor assessment? You know, anytime symptoms start in the teens or 20s, the very, very first thing we're going to probe is injury, pelvic injury. Were you an athlete? Did you ride bikes? Did you ride horses? Did you do ballet? Did you do gymnastics? Did you do ice skating? Did you take falls? Any traumas, any physical traumas when you were younger? And you go, okay, you go to pelvic floor PT. Excellent. So clearly your muscles are tight. Do we know why they're tight? Do we know why? Can you remember any trauma? Anything happened to your pelvis? One of the patients I was working with like a year ago was really, there were like two in a week. Okay. She was a cheerleader. And she was a big time cheerleader. Like she was a high school cheerleader, then she was a college cheerleader. And she had just terrible pelvic floor. And I was like, how many flying splits did you do? Because we were talking about trauma. Do you remember any trauma? And she's like, no. And I'm like, well, how many flying splits did you do? She goes, oh, a lot. And I went, there's your trauma. So the thing with dance, especially ballet, if you did ballet, is you're taught to tuck your pelvic floor under, your tailbone under, and then you're taught to walk that way. And that teaches your muscles into tension. Pelvic floor tension is very common in dancers. Yeah, and sexual trauma too. That's going to do it too. So the question now that you're going to physical therapy, what I want you to ask the physical therapist is, are my muscles responding to therapy, or are they always locking back down into tension? Because if your muscles are always locking back down into tension, we have to figure that out. Again, broken tailbone, funky SI joint, one leg longer than the other. But Abby, are you wearing high heels? I'm telling you, you start walking like this on your toe, whoo, that is going to mess up your pelvic floor big time. You know, feel free to call me this week. I'd love to talk with you. I'd love to talk with you. You can ask a lot more questions, you know, and see if we can try to answer this a little bit more. But again, I want you to talk to your physical therapist and just ask, are my muscles responding? She said, no, I'd fall. Yeah. You know, hey, listen, it's all about the best running shoes I can find, which are my Hoka shoes, although I don't run. I can't run. I have a partially torn ligament in one knee, so I've been able to run in years, but I can walk fast and I can walk up hills. And these are, if I'm not wearing my Hokas, I'm wearing my Nikes, you know, my Nike slip-ons. I have them in white and light blue, and these. I love these slip-ons. And they're cute. I think they're cute. All righty. Let's see what else. Oh, okay. So the other thing, and I don't know, you know, honestly, for those of you, because a lot of people listen to this after I've done this meeting. So it's not just a live, they're all recorded and you can listen to them on YouTube and on Facebook for 30 days, but on YouTube, they're there. The other really life-changing thing that happened to me in my 20s was a book that I was given. And again, my self-esteem was in the toilet. I just felt like a fundamentally flawed person. And I was very consumed by pain. I was just kind of that girl crying in the corner and striking out at people because I just didn't understand any of it. And I felt like I was going to be remembered as that pitiful daughter who never amounted to anything. I mean, that was really, I just felt pitiful. And I felt unloved and I felt unworthy. And I didn't know how to change that. And then somehow this book, I don't remember how I got this book, but it also was a life-changing book for me. And it was like How to Find Yourself in Your 20s. It was kind of like a book like that. And the first chapter was really shocking because it basically said, if you were to die today, how would you be remembered? Like, write your obituary. And so I wrote, in pain all the time, pathetic, unloved, unworthy. And I was just like reading this, thinking about all the bad things that my family, my friends would say about me, you know, and I was just bawling my eyes out. I mean, it was just, and then the next chapter said, how do you want to be remembered? Like, what do you want people to say about you once you're gone? So write what you would like your obituary to be like. And it's like, I want to be known as being kind. I want to be the person that people can call if they're in trouble. I want to be the person who stops and picks up the dog that was hit by the car, which I've done, and cat. I want to be valued. I want my actions to speak louder than anybody's words. You know, I just want to be a safe haven for other people. I want my home to be a safe haven. I just, you know, it just really made me think about how do I want to be perceived? And it was not sick. I want to be the helper. People say, go to the helper. I wanted to be that person. I wasn't at that time. But that's how I wanted to be. And so I write this all out and I'm, you know, bawling my eyes out. I mean, this was all one night. And then the third chapter was, okay, you just wrote the blueprint. Do it. Do it every day. Do something on your list. If you want to be kind, do something kind for somebody else. If you want to be the helper, go help somebody. If you want to stop and you want to help an animal, then do it. When you see it, stop and help them. And you actually wrote your roadmap. And that completely changed my life. Because from that moment, I went from being the pathetic Jill who's sick all the time to the kind Jill that people can call. The reliable ones that family can count on. Like yesterday, I went up and helped care for 2 3-year-olds. You know, and that's kind of like, you know, Abby, you're at that point where I was at, and you know, the hardest part about being in your 20s, I think, is like people expect you to know what you want to do. They know that you should know what your career is going to be. You should know all this. And you just don't. I mean, some people, when they're kids, they want to be a doctor and they grow up to be a doctor. I wasn't one of those people. There's a process of self-discovery happening that's a joy. Because you're at that age now where you just get to try stuff. I mean, you just get to try stuff. And college, oh my God, I love college. And I love college now. I love taking classes now. And the blessing of being older is you realize you don't have to prove any of it. You know, you'll know, you know, and for like the gift of college is for every question that you get an answer to you realize there's 100 questions and you don't have an answer to you. So it's humbling, but it's interesting and thoughtful. So, you know, you don't let pelvic pain define you in any way, shape, or form. Listen, you are an anatomical mystery to be solved. Let's figure out why it happened in the first place, work on that, and then you got to work on creating your life. Because you're a good person. You're worthy. You're lovable. You've got years ahead of you to do wonderful things. IC doesn't change your ability to love. It doesn't change your ability to be a mother. It doesn't change so much, but we got to work on kind of mental wellness, not kind of work on those affirmations, being bold, try new things, and just learning to live a healthy emotional life. And that's when those skills happen. It's in your 20s and 30s and 40s and 50s and 60s and 70s. Darla said, I bonked my bottom on a boy's bike. I couldn't pee for 3 days as a child. I rode every bronc I could find. I was a horse fanatic and danced ballet professionally for 13 years until you got MS. Yeah, girl, so your pelvic floor took a beating. You say, oh my goodness, that was so me. I'm 65, ran away home to Mexico 4 years ago and found my happiness. My father told me to leave town. No one wanted me there. He told me my son is a bipolar mess. I'm so normal. I'm so okay. Yeah, it's about finding your people. You have to find your people and make your home and about creating the home that you want to live. And some people have wonderful homes and some people don't. Some people have supportive parents, some people don't. Some people have nice siblings, others have mean siblings. In the end, it's not their responsibility to make your life, it's your responsibility to make your life. And as you try different careers and different classes and things like that, it's about finding things that you enjoy. It's like a career shouldn't be something that you dread going to work every day. A career should be something that's so interesting, so exciting that you can't wait to go to work every day. It's like, oh my God, I can't wait. And giving yourself permission to be bold. Like if you love the movies, it's okay. Like learn about it. Especially if you're a kid, you can go work on a movie studio. I have a niece who went to work at Universal Studios and she's now one of the big managers, and she went there when she was like 21. Dare to dream. I think in hindsight, oh my God, I would have loved to work in Disneyland. Like, why didn't I ever do that? Because I was in Southern California, but I was restrained, and I was scared because I'd been a trauma victim. You think they would hire a 65-year-old who's, when I retire, can I go work and volunteer at Disneyland? I'd probably love it. Darla said, I did save a pup's life. I do feed the stray within the last month. 2 people have told me I'm their angel. Yeah. You just got to do it. Listen, if you can look at yourself in the mirror at the end of the day and be proud of what you've done that day, that's a good day, my friend. That's a good day. And that's where the internet's so scary right now, because the internet is filled with people not doing things that are just the worst of humanity. I mean, please get off social media. And even though I know I'm doing this on social media, like don't live on Facebook or Instagram or TikTok. TikTok is just a cesspool. And Reddit is now kind of a cesspool too. It's just so much more important to just turn it all off and go get outside in the sunshine. Talk to your neighbors, talk to your friends. I did 2 walks like on Thursday. I did 2.5 miles in the morning. And then after work, like after 5, I went over to another area I like to walk and did a short walk. And I saw otters for the first time in nature. I saw 2 otters. It was so cool. Would never have seen it if I'd stayed home and been on a computer. All right. Okay. Now Karen said, okay. So we got Karen. You guys are good. You guys on YouTube, you're a little quiet. I got to tell you, there's a lot of research that came out this week. And one of them kind of pissed me off. Hold on. Let me see if I can find it. Hold on. It was a study on DMSO. Now, DMSO is a bladder installation. Oh, look, here's an even, oh, wow, holy hell. Yeah, here it is. So, it just so annoys me. DMSO is a bladder installation that is FDA approved for IC. And its brand name is Rimzo 50. So DMSO is a byproduct of the paper industry. It was originally created back in the 1950s to try to help move transplanted organs from one hospital to another. If they're doing a kidney transplant, you can't store a kidney in ice. The ice crystals will kill it. So DMSO, somebody created DMSO, you can put a kidney in it and it doesn't damage the kidney and you can take it to another hospital. And at one point in time, DMSO was considered kind of a wonder drug. Like, whoa, this is the next greatest thing. This is going to help a lot of people. So back in the 60s, they were testing DMSO with a ton of medical conditions. Like, this is it. This is a wonder drug. It failed everything but the IC study. The IC study showed a little tiny bit of a success. I actually interviewed the guy who did the study. He's the same guy who wrote the patient notes for the FDA approval. And they were kind of fanatics about DMSO. I mean, they were like, use it any way you can. Put it in your bladder, put it in your blood veins. They created MSM to take orally. I mean, they were all on the DMSO train. But now, and I still remember like 3 or 4 years after I started the IC Network, like in the mid to late 90s, a researcher named Sisuba Packer did a very important DMSO study that found that the FDA-approved dose caused irreversible bladder spasms. And she was testing DMSO on rabbit bladders. And that when you put a 50% concentration of DMSO in the bladder, the muscle spasmed and locked into spasm. Can you imagine? Oh my God. And so she did dosing 25. So 20 was fine, 20 was fine, 30 caused the start of spasms, 35 more, 40% more, 50% irreversible bladder spasms. And that was presented at the very first American Urology Association conference I went to in Los Angeles. And I went specifically because of that study, because everybody was going miracle drug. And then this happens. It's like, oh my God, the FDA approved dose could do this. So I walked into that convention center and I went to that portion of the meeting, and I talked to every single IC specialist there, all the top dogs. And I was like, what do you think of the DMSO study? And pretty much every single one of them said, well, we don't do it anyway. And with the one doctor who I'm still pretty good friends with said, there's a place for it. But for the most part, we don't use it. So DMSO fell out of favor as a bladder installation years ago. One of the reasons why is because it hurts. It can hurt. And you get this garlic-like smell, which is not nice, and in contrast, the bladder installation that's much more popular is called the heparin installation, a rescue installation, which combines heparin and lidocaine, which you put it in the bladder, and most people, it just turns the pain off. So if you have a choice between doing a bladder treatment that will hurt for hours or a bladder installation that will make you feel better, yeah, come on, give me the one that'll make me feel better. So DMSO, in my opinion, has fallen way out of favor. It's an old therapy. I don't even think it would be approved today, to be quite honest. But it's still out there. And so like, oh my God. This is a study that tested the ability of DMSO to reach breast milk in mothers with IC who are nursing. And they tested mother's milk after having one DMSO treatment. If you're nursing, you would normally not do this, do a treatment. And I look at a study like this, their conclusion is, the findings of the study demonstrate that DMSO's transfer into human milk is minimal. Additionally, the study provides the first quantification of DMSO in human milk. I'm sorry. I don't think any infant should be exposed to any of this. How can anybody say that that is safe? We don't know if that's safe. We don't know how an infant's bladder is going to respond to any DMSO. So I read this and it's like, and this study was done in Texas, at Texas Tech. God, I'd sure love to know the motivation behind this study. Because to me, what it says is, hey, if you're pregnant or you've had a child, it's okay to use DMSO. I don't know if that's true. That's the general implication of that. But I haven't read the full study. I just read the abstract. Susan said here, oh, Abby said she got heparin. Okay. Susan said, I did lidocaine, heparin, and sodium bicarbonate back in 2018, and they did not work. Okay. So Susan, remember we have phenotypes. So we're not all the same. So if you have a Hunner's lesion, is that going to work? No. If you have pelvic floor tension, is that going to work? No. If you've got widespread pain, is that going to work? At best, temporarily. The only person that's really going to help is going to be the bladder wall-driven estrogen atrophy or chemocystitis, in my opinion. All right. So, okay, we've got 7 new studies this week. So let's look at these really quickly. And hold on a sec. Okay, so we've got, so you guys are still hanging out, so that's good. So here's our first study, preclinical models of female pelvic pain disorders. Pain is influenced by a complex interplay of biologic, psychological, and social factors. Sex has emerged as a key determinant in the vulnerability to chronic pain and a major risk factor for a poor response to available medications. Women report higher rates of chronic pain and exhibit greater pain sensitivity. Hello, estrogen. However, the underlying mechanisms are poorly understood. So they're trying to understand why. Okay. Preclinical models. Yeah. I don't know. I mean, it's kind of obvious why. Okay, where is this study being done? Italy. Okay. And I got to say, listen, Italy's doing great IC research right now. So I'm not going to throw it out just because it comes from Italy. Italy's done more out than others. Ooh, my incision just zapped me. Low-grade urothelial carcinoma of the bladder presenting as PGAD. Interesting. Okay, so somebody that thought they had a nerve compression when it was actually bladder cancer. The prevalence of fibromyalgia in the general population, okay, that's not helpful. Transurethral injection of micronized fat tissue for refractory IC, a retrospective pilot study. Ooh, let's look at that. So we've already done that here in the United States. The California Stem Cell Center did adipose derived, which is fat. They would do a liposuction, grab some of your fat, and then break it up to get the growth factors and the stem cells, and then stick it back in. And the results were, so let's look at this here. We conducted a single center retrospective study of 20 patients with refractory IC treated between April and October 24. Fat tissue was harvested by liposuction and mechanically processed using a closed system. Okay, so that should pull out the stem cells and the growth factors. This was then injected into the bladder submucosa. Patients were evaluated at baseline 1, 3, 6 months. At 6 months, 65% met. 65% had 50% or greater improvement in pain or urgency. Significant improvements were observed in the IC test, the questionnaires they were using. So what's the conclusion? In this exploratory pilot study, the transurethral implantation of micronized adipose tissue was associated with improvement in symptoms. These results support the feasibility and potential role of minimally manipulated fat-derived therapies in this setting. Okay, this is just something very similar to what we did here in the United States a decade ago. The challenge with doing this is that it can be very expensive. The California Stem Cell Treatment Center charged either $6,000 or $8,000 to have it done. This was patient funded. It was not covered by health insurance. The results were not what we call durable. What that study found with Dr. Elliot Lander is that patients had a short-term improvement in their symptoms that wore off, and they'd have to go back each time for a $6,000 treatment, and that was not viable. So then I'm pretty sure they stopped that study. Good to see. Yeah, that's pretty much it. I don't know what this is. Developing a personalized best medical care with integrative mobile palliative and telemedicine support. Yeah. All right. So I did send out a clinical trial announcement. There is a company that is testing a new bladder rescue installation, kind of a prepackaged rescue installation. So for those of you who get our mailing list, please know that that is an absolutely valid study. That is a good study. And they're seeking patients with pain, men and women who would like to try that. If you go over to the IC Network, go into our clinical trial center, it's under research. You can get the contact information. There were research centers across the United States. So that is a thing. The importance of clinical trials is you get treatment for free. It allows you to go work with and see some of the best doctors in the country that it might take you 6 months to wait and see. It's kind of what word did I use in our last meeting? It's like a free ticket into their office. If you express some interest in participating in a clinical trial. You don't have to, but you could learn more about it. I hope that makes sense. The other thing too is our new iPhone app, IC 101 Food app is alive and kicking. It is on the Apple Store. We are right now making the Android version, and I do not have an Android phone or an Android iPad, so I need a couple of patients to help me test it. So I need some volunteers. I've already got one person who's volunteered, maybe a couple more, where we can have you. So the app, I don't even have anything in here with me. It's here, hold on. All right, let me show you. I can show you on my iPad better than my phone. For some reason, the glare from my phone makes it almost impossible to see over the computer. Okay, here, hold on a sec. Let me just clean this screen. My iPad takes a beating every day. Okay, so okay, let me try this. Let me see if I can show this. So there's my iPad. You can see what I have on it. And if you see the watermelon, that's the app. So let's click on that. The IC 101 food app, and it immediately goes to categories. So fruit and vegetables, grains, breads and pastries, dairy, meats, beverages, snacks and sweets, spices, condiments, vitamins and supplements, etc. So you can click on fruits and vegetables, and then it starts with A, apples are the first one. And there's this massive list of veggies. And then when you click on apples, it will tell you bladder friendly, try it, and caution. I don't think, oh, this is a better way to see it. This would mimic more of a phone or an iPad. So let me go to dairy, cheese. See? So what's bladder friendly? American, mozzarella, cheddar, feta, ricotta, string cheese. What's worth a try? Blue cheese, brie, brick, parmesan, camembert, and then caution or a cheese in a can products, things like that, right? Okay. If you go up to the search area, you can click on search and you just type in. So, and it will immediately show you everything. So I put in cheese and it immediately showed cheesecake, pizza, stuff like that. But what makes this revolutionary, we've never had this before, is an AI section. But the AI is based on our website. It's not information from the web. This is our diet list, so the data is all fact checked. And so you can ask it, can I drink coffee? Okay. And let's see what it does. So it's thinking. You can see it's thinking. I'm so excited by this. Abby, you can? Girl, okay, good. So what is it saying? Hey there, I understand you're curious about drinking coffee and I'm here to help you. Let's break it down. Number one, traditional coffees avoid due to their high acidity and caffeine content. Traditional coffee is generally not recommended for those with bladder sensitivities. Number two, low acid decaf coffees, worth trying. Number three, herbal coffees, bladder friendly. These are excellent alternatives. And they say here, when you think about drinking coffee, consider switching to a bladder-friendly alternative. Pair your coffee with bladder-friendly snacks. Conclusion, while traditional coffee may not be the best fit for your bladder health, there are certainly alternatives to enjoy drinking. If you go for low-acid decaf or herbal, you'll likely be much better off. I mean, guys, how cool is this? This is so freaking cool. I have now. I didn't know we could do this. I met an app developer from Chile of all places, and he built it for us. Susan, it's in the App Store. I can get it for you. Here, hold on. So anyway, yes, I need a couple of Android users to test it on your Android device. And it's probably not going to be ready until next week. So if you can email me, my email is icnetwork@mac.com, icnetwork@mac.com. Email me that you want to do it, and I need your phone number because I'll have to call you to explain how to add the app, and then we'll FaceTime. So when you get the app, we're going to have to FaceTime because I need you to show me what it's doing. No, Cheryl, it's available right now for an iPhone. It's in the App Store. Oh, yeah. So iPhones are fine because I live on Apple devices. You are good for iPhones. It's the Android devices that I need testers for. So let me get you the link. Hold on. Let me see. I have a blog on it on the IC Network that has the link in it. It's not free, guys. It's $4.99. So I can't do it for free anymore. I lost so much money on our first app because it was free. So, but it's under $5. So you can try it out. And if you don't like it, you can cancel it. But just know that I'm trying. We're trying so hard to make new things. Okay. So here is the blog on it. Yes, Susan, it is. So you can use it for a month and you can just cancel it. Listen, the first two apps I built cost me, between the two of them, probably $70,000 to build. And they were free and we gave them away. And we can't afford that. We can't afford to give it away anymore. Times are too rough for everybody. Plus, now that it has AI, it has great, even more value. Because this isn't a food list. This is an app that can help you reduce pain and prevent pain, with an opportunity to interact with AI. And even more importantly, I get to update. I mean, like if you have any questions, if there's a new food that's not in there, I can literally add it on the fly because it now lives in a database. I don't have to pay $10,000 every time we update it. I can do it. So I'm super, super excited that we have this available now. And oh my God. Okay. So like, one of the things that I have been trying to map out for a decade, and I like literally, oh, it's like over here. Here, hold on. Is this it? So this is what I do, is that I will, when I'm making something that's really complex, that has a lot of pieces to the puzzle, I map it out with Post-its first, right? And so, and this isn't this is, which one is this one? This is the IC 101 Masterclass. That's that map. So I have another map for a flare guide online where literally, hey, I'm in a flare. I don't know what kind of flare this is. Can you help me? And it's going to ask what your symptoms are. What do you think triggered your flare? And then give you a rescue plan. It's like our flare guide, you know. So the app, the food app is based on this, the new diet guide, right? The flare app, it will be based on this, which is our flare guide. I can't, there's so much I want to do. I just don't have the money to do it. You know, it costs a lot of money to do these things. So anyway, okay. Zanya here on YouTube says, I would like to know a little bit about hydrodistensions. I had an awful first visit with urology, and they basically said, if I have IC, a hydrodistension should have worked, but that doesn't seem right. No, that's weird. So we talked about this at the very beginning of this meeting. A hydrodistension, hydro means water, distension means stretch. So what they do is they fill your bladder with fluid and stretch it out. Hold it there for a little bit of time, drain it out. Sometimes they do it twice. And then what they do is they use a cystoscope to look in the bladder to make sure the bladder wall is healthy. You know, that's a really good way of looking at Hunner's ulcers and also doing treatments, like if you have a Hunner's ulcer that they need to treat. The reason why hydrodistensions sometimes are therapeutic is because when you stretch the bladder, you break all the nerves in the bladder wall. You stretch it, they break. And so you get this false sense of, oh my God, I feel better. I don't have as much pain. I'm not peeing all the time. Well, it's a false sense of security because the nerves always grow back, always. And sometimes more nerves grow back than you originally had, which is not good. So a hydrodistension is what I call a destructive therapy. It works because it breaks something. But the human body is always, is always wired to heal. The human body is going to try to fix that. But in the end, it will never get you healing in the long run. And that's our goal, Zanya. Our goal is to try to identify what the underlying problem is. Is it a Hunner's lesion on your bladder wall? Is it estrogen atrophy? Is it a chemical injury to your bladder wall? Is it a viral infection? Is it a fungal infection? Most patients have very tight pelvic floor muscles. So now we really don't consider IC a bladder disease. We consider IC a pelvic pain syndrome. And 87% of patients have a neuromuscular cause of their symptoms. We have a normal bladder. My bladder was always normal whenever they looked at it. And they've looked at it 3 times. I was bawling my eyes out in bladder pain. And yet they look at my bladder and go, Jill, it's fine. I'm like, how is that possible? I'm in agony right now. And the reason why that was possible is because it really wasn't my bladder. It was an old pelvic injury. I had broken my tailbone and my pelvic floor muscles were as hard as concrete. Muscles are not supposed to be hard. Muscles are supposed to be soft and pliant. You know, a healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like a overcooked rubber chicken breast. With a little bit of give to it, but it doesn't feel real healthy. And a really badly damaged muscle feels like beef jerky. And so the role of a hydrodistension used to be a gold standard diagnostic test for IC. You know, back then they thought that what we call petechial hemorrhages, little red dots on the bladder wall, they thought that was a bladder disease. I have pictures here. Hold on. So here, let me show you. I've got good pictures. I need to reprint those out, as a matter of fact. What is that article doing in here? Oh, that's why. Okay, hold on. Okay. Okay. So what does an IC bladder look like? Right? I mean, that's such an important question. What does it look like? Well, when the cystoscope was invented back in the 1920s, that allowed them to look inside the bladder for the very first time. And some patients had a Hunner's ulcer, very visible. So this is a picture of a Hunner's ulcer. So they generally have a big red center with big arms. So back in the 1920s, Dr. Guy Hunner was the first to identify lesions, which is why they call them Hunner's lesions. Now, this is only in about 5% of patients. And so the upper ones are inflamed Hunner's lesions. The lower ones are non-inflamed or resolved Hunner's lesions. So these right here have turned white. So those are considered resolved. Okay, but the other thing that they found were little red dots. Most patients after a hydrodistension had little red dots. We call these petechiae or petechial hemorrhages. So for many, many years, everybody thought this was the bladder disease. We knew Hunner's lesions were rare. This was very, very common. And then in 1987, when the National Institutes of Health created their very first diagnostic criteria for IC, they said a patient could be diagnosed with IC if they have this or they had this. But then there was a doctor who went, not so fast, not so fast. He took 50 women who were scheduled for a tubal ligation, no bladder symptom, and said, would you let me look at your bladder more closely with a hydrodistension? And he got 50 volunteers. So again, no history of any bladder issues. When he did a hydrodistension, what happened? This happened. This happened. It turns out that when you stretch the bladder, you're breaking things. And this is an example of skin getting torn from stretching the bladder. We call this, again, petechial hemorrhages. So that was when doubt was raised about petechiae as being meaningful. And if you look at our latest, okay, so the first thing that happened is I think they realized that the more you stretched the bladder, the more this happened. And so if you look at our national guideline, the first guidelines in 2018 said no more high pressure hydrodistensions. You know, high pressure means you put a lot of water in it under pressure and you hold it in there because that does damage. In some patients, their bladder is ruptured. You put a lot of fluid in there and you force it in there, of course you're going to overstretch it and potentially damage the bladder. And you can go back in time and you can read lots of posts of patients who had hydrodistensions back then who were damaged by it. So if you look at our national guidelines, they said no more high pressure. We're going to do low pressure, short duration to minimize bladder trauma. Okay. So the goal here then is to try to stop this from happening. Our goal is not to do harm. The goal is to just take a quick look at the bladder the easiest way possible without damaging the bladder a little bit more. So the operative word, Abby says she's on a wait list. You're going to ask, can I have a low pressure, short duration? You want to minimize bladder. But see, you know, Abby, again, she says, I'm on a wait list for a hydro. I doubt it will work. Well, no, it's not going to work in the long run. It's not. It's just going to break things. You're going to feel better temporarily, but the nerves are going to grow back. The far more important question is, what are you going to get out of it, doctor? When you do it, are you going to take a close look at my bladder and tell me if my bladder's healthy or not? That's legit. It's always good to let them look at least once. They've looked at my bladder 3 times. 3 times my bladder's been perfect. I'm not against cystoscopies at all. I don't like guessing. I like facts. When I'm in pain, I want somebody to look at it. It's perfectly reasonable to let a doctor look in your bladder, because if you don't, you're forcing them to guess. And you deserve more than a guess. Now, so the question then is, do they have to do the hydrodistension, or can they just do a cystoscopy? I call that a looky-loo. They just numb the urethra, stick the scope in, take a look around, pull it out, you're done. 5 minutes later, you're done. And the bladder's not traumatized at all. The urethra's traumatized, but the bladder's not traumatized. So if they want to do the hydrodistension to look at your bladder, or just, you can say, well, I don't really want the hydro, give me the cysto. I just do the cysto. I'm all for you looking at my bladder. Okay. In the long run, we have to know what we're treating. We don't want to guess. We need facts. What's the health of your bladder wall? What's the health of your pelvic floor? What's the health of your nervous system? What's the health of your skin? And then based upon that, that's then how your treatment should be determined. I don't know anybody now who is using hydrodistension therapeutically. I mean, it's mentioned in the guidelines, but it's what I call chasing the symptoms. You're chasing the symptoms, but you're not fixing anything. And we want to fix things. You know, we want to fix things. So you need a proper phenotyping. So call me this week, and I can do that over the phone and at least give you a better idea of what your phenotype might be. And then we can go back to that doctor and say, okay, I've learned a little bit more about IC now, and I'm really interested in getting your opinion on this, and maybe I want to try this treatment rather than that treatment. Your urologist told you to try the hydro, and if it doesn't help, she's sending you to a pain clinic. Okay, I get that, but do you know what your phenotype is? Do we know what we're treating? Do we know what's causing your pain? That's the critical question here. Is it Hunner's ulcers on your bladder? Is it a chemical injury of your bladder? Is it estrogen atrophy of your bladder? Is it a tight pelvic floor? Right, Abby, you don't. And that's a missing piece. So call me. Call me tomorrow. You see my phone number right there. It's an 800 number. We'll talk about it. It takes me about 5 minutes to do a reasonable phenotype, at least what I think your phenotype might be. And then I give you a list of questions and send you back to your doctor with the different ones. So Cheryl's saying, what's a phenotype? So a phenotype is a group. It's a group. So not every patient is the same. We're different. And our job is to try to figure out what group you belong to, because each group has their own treatment. Not every patient is the same. We're tremendously different. And we also know that bladder therapies don't work for a ton of people. And Abby said she had a cystoscopy before, no Hunner's lesions. Exactly. Me too. Me too. But we know you have tight pelvic floor muscles, right? So the question then is it the muscles that are driving all the pain? And if that's the case, a hydrodistension is pointless. So call me. We got things to talk about. I can kind of walk you through that and then give you some ways to do that. Right, right. So one of the classic phenotypes, let me just kind of see classic presentation. So anytime symptoms begin in younger folks, teens, 20s, we always going to look at injury first. The great majority of those patients have pelvic floor injury. The great majority of them. The small group of them might be in the widespread pain group from trauma, but tailbone injury, sports, traumas, accidents, anything that's affected the pelvic floor, difficult childbirth, riding bicycles for a long period of time, weightlifting, military service, being a paratrooper, anything that jars the pelvis, traumatizes the pelvis, rape. That's really what we're going to look at first in somebody who's younger. We don't see bladder disease in younger patients, although there's always exceptions. Always exceptions. I've worked with some patients have post-herpetic pain syndrome. Yeah, that's right, honey. 7496. So post-herpetic neuralgia, endometriosis, tailbone injuries, fibroid tumors, pelvic congestion syndrome. Those are things that can also trigger symptoms when you're like in your 20s to 30s. If your symptoms began after hysterectomy, if your symptoms began when you went on Lupron for endometriosis, we're going to look at estrogen atrophy as your underlying phenotype. The loss of estrogen directly affects the bladder. Your bladder defends itself with a really thick coating of mucus. And the purpose of that mucus is to act as a barrier and protect the fragile cells. So your bladder is actually like your mouth. It's a hollow organ that's wet and slippery on the inside. And that wet and slippery mucus is a really thick protective coating. It's important to the health of the skin. Unfortunately, it's also estrogen dependent. So what does that mean? It means that when you're young and have a lot of estrogen, you got a lot of mucus. But if you're older or you're on Lupron or an estrogen suppression med for cancer, guess what? You don't have the estrogen anymore, which means you really don't have a lot of mucus anymore, which means your bladder's ability to defend itself is now greatly compromised. And that one cup of coffee you used to have every day in your 30s, guess what? In your late 40s, can't do it. And it's going to feel like a UTI, but it's not a UTI. It's the fact that the coffee is now penetrating through the mucus because you don't have a lot of mucus and it's irritating the nerves of the bladder wall. The caffeine is doing that. The acid is doing that. So estrogen atrophy is a really big chunk of female patients. And for men, the biggest chunk is injury. And then, of course, we've got the widespread pain group, patients who have multiple pain conditions, because that's driven by the central nervous system. So we have to understand the health. And I mean, in the end, it's really easy. It's like, what is the health of my skin? What is the health of my bladder? What is the health of my muscles? What is the health of my nerves? And based upon what we find there, that targets treatment. If your nervous system is messed up, then we've got to work on that. If your muscles are messed up, we got to work on that. If your bladder wall's messed up, we got to work on that. If your skin is dry, we got to work on that. There's no single treatment that's going to do all that. That's why we phenotype. Abby said no endo. Thankfully, you had a laparoscopy in December. I had a laparoscopy too, and I had no endo either. And in the end, all of my symptoms were being driven by a very sensitive nervous system combined with muscle tension. So again, the hydrodistension is kind of like a wild shot in the dark that doesn't make a lot of sense. You woke up sobbing? Yeah, honey, I'm sorry. I'm sorry. I woke up from my laparotomy, which I had in September 1993. And again, I was completely convinced that I had massive cancer that they had missed. That's why I had it. I mean, I demanded it. That I don't believe you when you say I have IC. I want you to open me up. I'm dying right now. My pain is so severe. It's got to be cancer. And yet it wasn't. And you know, and the really interesting thing is you know, he said to me then, it's not your bladder. There's just, we're not seeing anything. And he's like, it's got to be your nervous system. It's got, you know, you're a redhead. Your nerves are really, really sensitive. And it's kind of offensive that is, it was absolutely spot on. And then, you know, what's hysterical is I had a hysterectomy 7 years ago. And they did a hydrodistension and looked at my bladder to make sure they hadn't actually damaged my bladder during the hysterectomy. And he took pictures of my bladder and he showed them to me. I had a perfect bladder. Like there was like one tiny red spot among my entire bladder. He goes, Jill, this proves once and for all, this was never your bladder. Never. This is entirely neuromuscular for you. It's nerves and muscles that are the problem, not your bladder wall. And unfortunately, when the nerves and muscles get messed up, it affects the bladder and it gives you some of those symptoms, but bladder treatments don't work. We have to do muscle treatments and nerve treatments. Abby said, they gave me an IUD to help the pain. What? Doesn't do anything but make it. You know, Abby, here's the challenge with Western medicine. Every doctor plays in their sandbox. You go to a urologist, they're going to assume that it's the urinary tract. You go to a gynecologist, they're going to assume it's reproductive tract. Go to a gastroenterologist, they're going to assume it's a bowel. And they don't look at connecting factors. Nothing operates in isolation in the pelvis. It's a small confined area. Everything influences everything. And the muscles and nerves influence everything. So the person who gave you the IUD to help the pain, they're assuming it's gynecological, and it's probably not. It's probably your muscles. At your age, it's probably your muscles. All right, guys. Well, we have been going for 3 hours. Man, the day has just flown by. Wow. I think it's been a good meeting today. So let's do a last call for questions. Last call for question. You know what? I think I want to drive out to the coast. It's a beautiful day. Oh, I don't know if there's fog. I don't want to drive to the fog. It takes me about 45 minutes to get to the beach. You're welcome, Cheryl. Hold on. Let me see. Is it foggy in Sonoma County right now? It would be a total waste of time to drive out there if it's foggy. Patchy foggy. Okay, if I'm going to go to Bodega, will there be fog there? Bodega Bay. Clear and sunny. 65 degrees. I don't know. We'll see. We'll see. Thank you, Susan. Yeah, it was a good meeting. Good meeting. Hi, Peggy. Peggy's on estrogen, 5-BID, along with the lactoferrin. I'm also on estrogen vaginal cream for 2 years, which has helped quite a lot. Go to the beach and have some fun. Thank you. Yeah, I might do that. I've been wanting to do that. Sonia says, thank you. We know I have Hunner's ulcers and tight pelvic floor. I was untrusting of this doctor and I'm bringing a relative to my next appointment. So listen, the fact that you have Hunner's lesions validates a hydrodistension. Because that's the only way they can treat it. They have to do a hydrodistension to get a close look at the bladder wall. So is a hydrodistension going to help a Hunner's lesion? No. Would a cauterization, a steroid injection that they do into the lesion during a hydrodistension help? Yes, it might. So I think there's some mixed messages that you're going to need to clarify. Okay. Sarah says, I'm thinking of trying to see a urogynecologist, fewer of them than urologists. Nothing wrong with that. I have painful periods, uterine ablation discussed with PCP. Uterine ablation is a big deal. That is a big deal. My best friend had a uterine ablation. What does PCP stand for? My brain is zoning on that. Hold on a sec. PCP gynecology. What is that? Oh, well, you're not referring to your primary care provider, are you? Oh, I get it. You discussed it with your primary care provider. Urologist recommended ultrasound and Botox. Any input on Botox for the bladder? Okay. What are your bladder symptoms, hon? You have painful periods, but you haven't said anything about bladder symptoms. What are your bladder symptoms? Like, are you sleeping at night? Are you having frequency? Are you having pain? What are your urinary symptoms? Of course, the more I drink water, the more I'll have to go to the bathroom. And the bathrooms are pretty Spartan out there. So what are your urinary symptoms, Sarah? While you're answering that, I'm going to go use the restroom. I'll be right back. All right, Sarah. Ultrasound would be very good to check the thickness of your endometrial lining. If your endometrium is unusual, okay, here she says, I'm sure I have some leakage. I'm not good at describing symptoms. I've been under the care of different urologists since my diagnosis in 2008. Your current urologist is a longer. Okay. Okay, so we have phenotypes now. Not every IC patient is the same. Botox's use is pretty minimal now. If you have Hunner's lesions, Botox is not particularly effective. Hunner's lesions have now been linked to viral infections and also some neuroinflammation. If you have a chemical injury to your bladder from ketamine or from another chemical, Botox is not going to do anything. We've got to figure out what the chemical is and let the bladder heal. If you have estrogen atrophy, all Botox is going to do is temporarily silence nerves. It can turn off frequency, urgency, and even pain for a short period of time, but it's always going to wear off. And then you're going to be in pain again. So it is what I call, it's chasing the symptoms. It's not fixing anything. The problem with Botox is if they accidentally silence the nerve that helps you urinate, you might have to self-catheterize. So Botox is not supposed to be used in patients who are unable to self-catheterize. If you have tight pelvic floor muscles, sometimes it will do Botox into the muscle, and that's a viable treatment for very tight pelvic floor muscles. If you have widespread pain, again, all it's going to do is temporarily manage symptoms. It's not in the long run going to repair anything. So we don't, if you look at our national guidelines for Botox, its use has gotten pretty slim. It became popular 20 years ago, 15 years ago, when we thought IC was a bladder disease. But now that we're phenotyping and now that we recognize that there are different patient groups, it's just not used as much. All right, guys. Well, listen, I try to do these meetings every Sunday, but you can reach me throughout the week. There's the phone number. Feel free to call. I'm always happy to talk to anybody. First come, first serve. If you get my service, that just means I'm already working with somebody. I'll text you back and I'll say I can't talk right now, or can I call you later? And so if you get that text back from me, don't assume that I don't want to talk to you. It just means that I'm already working with somebody. It's okay to be the squeaky wheel. It is okay to call multiple times. I'm perfectly okay with that. Sarah, we have a big section on Botox. Well, not big. We have a section on Botox over on the IC Network website. So just go over to icnetwork.org and look at the treatments, and you can read about it there. Okay? And I'm happy to take any questions you have. All right, guys. 3 hours. We did it. Woo! I don't think I have it in me to do 5 hours today. So, all right. I'll see you later. Have a good one. I want to get out and drive a little bit. Oh, wait a second. Hold on. I missed a question on YouTube. Hold on. Dairy products, milk, and so on give me a flare when you're sleeping, especially wakes me up all night, many times in. Who else? Dairy products are not, wouldn't irritate the bladder from an acid standpoint. If you're doing chocolate milk, something like that, the chocolate has caffeine in it, which is neurostimulatory. It's quite possible, though, that if you have a lactose problem, that you're having kind of an allergic reaction to dairy. But dairy, by its very nature, is not acidic enough to irritate the bladder. But if you're lactose intolerant, that could be another issue. If there's something else in the dairy, like chocolate ice cream, chocolate chip ice cream, things like that. Yeah, it could irritate for sure. You can go on over to our food app, or you can get our food guide, the IC 101 diet guide, and that will give you a lot more tips on dairy. All right. All right, guys. I'll see you later. Have a good week. I'll see you next week. And if you find these meetings helpful, if you want to know when I go live, make sure you subscribe, follow the channel. And for those of you who are listening on the internet a week from now, thank you for listening for an entire 3 hours. I'm here for you. And if you like what we do, make sure you become a member of the IC Network or buy something in the IC Network shop, because that's what pays the bills so I can do this. All right. Okay, guys, I'll see you later.